Our next interview doctor is Dr. Kim Bowen, who's had extensive experience here in the Medina area for many years. And Dr. Bowen's going to talk about different topics, especially around emergency room treatment and other topics as we go through the list here. So why don't we start with just telling us a little about when did you begin practice in this area?
In about 93, when I came out of my residency, I wanted to come back to Cleveland. I did my residency up in Detroit. And I worked at Charity Hospital, St. Vincent Charity in downtown Cleveland. Back then, we didn't have trauma centers. So for me, it was kind of fun. You would get gunshot wounds, stabbings. You know, at Charity, I would get all kinds of stuff. So as an ER doc, you were trained to deliver babies, so I would deliver maybe 1 or 2 babies a year. I would crack a chest where you open up the chest and grab the heart and sew it. I would do that once or twice a year at Charity because they did have cardiothoracic to back you up and take you to OR. So it was a lot of fun, and I ended up buying property and buying a house down here in Medina. I grew up in Parma. My mother would tell you Parma Heights, but I grew up in Parma, and my dad and I would come down here to go fishing at Lake Medina or whatever, and I just really loved the area when I was growing up.
Huh.
And that's why I wanted to move down to this area. So I came down part-time in 93 and then full-time in 98. I was the co-director with Dr. Dodd for about 2 or 3 years, and then the director for until 14 when we turned over to the Cleveland Clinic.
What would you say would be the most major changes you experienced in treatment over the course of your practice and from when you started to present day?
Oh my God. We were very invasive before the advent of MRIs and ultrasounds and CT scans. As we had talked about before, CT scans, when I came out of residency in 90, you know, the tertiary centers had a CT scan for stroke or for head bleeds, but they didn't do the body. They didn't do anything else. Ultrasound was rarely available depending on what hospital it was at. So we were very invasive. So give you an example, if you were in a car accident and you had all kinds of belly pain and I suspected that there was bleeding internally in you, and I couldn't get the general surgeon to come in to take you for an exploratory lab, then I would do what's called a perineal lavage is what I would do. And that's where you'd stick a tube into the abdomen, you put normal saline fluids through, you analyze the fluid, there's blood there, then you call the surgeon, he has to come in. And take him to the water.
Wow.
You know, so we used needles all the time. You know, a pericardial infusion, if you thought there was fluid around the heart, you put a needle in the chest and did it that way. You didn't use an ultrasound to determine that.
So, given all those movements in the industry and so forth and in the practice of medicine, what changes in medicine saddens you the most nowadays?
Oh my God. When I came out of residency, for every hour I spent in the emergency department, at least 45 minutes of that was talking to the patient, talking to their doctor, touching the patient, examining them, whatever that may be. And then the other 15 minutes was writing my 1-page note and turning around and looking at an x-ray or an EKG or that kind of thing. When I retired in retired at the end of 2017 and beginning of 2018. When I retired, it was just the opposite. 45 minutes on the computer, 15 minutes actually seeing the patient. And I gotta tell you, I don't care if you're a nurse, a doctor, a paramedic. You know, the reason you go into medicine is to take care of people, not to be on a computer and, you know, try to fill in all the words you need to fill in for the computer, whatever it may be.
It's interesting you say that. The other physicians we've interviewed so far have indicated almost the same sentiment, that as you look at the future with AI and advances in medicine, do you foresee that going back to more hands-on?
That's a good
diagnostics?
question. I don't know, Brian. I'm not sure. I am concerned about our grandchildren because I don't know, I don't want to sound corny, but when people went into medicine when I was younger, sometimes it was like a calling, as corny as that sounds, whether it be a nurse or a doctor. And now it's not. It's a job. It's a job that pays you okay and pays, so I punch in, I punch out, you know.
Did you have a mentor or two that worked with you along the way as you developed your skills? Any one physician stand out?
Mark Bronigan. I'm sorry. Mark Bronigan from Detroit, from Mount Carmel Hospital in Detroit. It's now, you know, the hospitals get bought out and everything, so it's now with Detroit Receiving is what it's with, that group. But he was fantastic. He was fantastic. Him and maybe Craig Elmitz as well. Mm-hmm. And ironically, Dr. Elmitz is not an ER doc. But when I first applied to medical school, I got interviews at all 7 in the state of Ohio. I didn't get in. I didn't get picked. So I went to Case Western Reserve in the research department and got a job with Craig Elmitz. He was a dermatologist. And he mentored me through the younger part of my career, just because of the way he looked at research and the way he looked at things. And we published, I don't know, 5 or 6 papers together, and he was really a powerful guy. Mm-hmm. You know, very quiet little guy though. I mean, he was not, you know.
Well, today, your involvement with the Free Clinic of Medina County is quite important. How do you think doctors years ago would have looked at the concept of a free clinic, or did they actually practice free medicine in trade or bartering with residents?
You just said it. They practice free medicine. Yeah. So back in those days, if a patient couldn't afford it, they would sit there and say, okay, well, bring me a chicken or a couple eggs, you know, or, you know, whatever you think you can afford, you know, and that's the way it was looked at.
Well, if you had to give advice to future people in the medical field, what do you think would be the most important advice you could give them?
That the most important, just don't lose track of the most important thing, and that's the patient. You know, and don't lose track, don't get involved in trying to understand too many things or try to do too many tests or, you know, take home understand what that patient wants and what they need. You know, the problem with medicine is that you are taught that if a patient dies or has a bad outcome, the first person you need to look at is you in the mirror. Did you do it? Did you not do something that needed to be done or whatever? And because of that, doctors overdo things. We overdo stuff. We, do way too many tests on some things. And if someone is 80 years old and has metastatic cancer, why are we putting them on a vent? So towards the end of my career, in the beginning of your career, you have to save everybody. Oh, no, you don't. Sometimes God's going to take them, and you just flow with it. So at the end of my career, I was notorious for having conversations with families and with the patient and pulling their tube and having the family come in and pray with them and just be with them during the last few minutes, and made a lot of nurses cry. But it was good. It's what it should have been.
I can imagine the emotions, especially in the ER, could run quite high. But what would you say when I was young, people joked you had to go around the back of the hospital and ring the buzzer to get into the ER. And I was included in that. My first trip to the ER, that's exactly how we went. But then I also witnessed the rise of the life support team coming into play. Now our paramedics and police officers are trained in at least triage medicine.
Oh my God, yeah.
And has that helped the ER situation move patients better or faster by having that pre-treatment?
Oh, it's let me give you, God, you're going to get on another one of my pet peeves. In 95, I started the Mast CPR training in Cleveland. And I did that in Cleveland. And the reason being is in Seattle, to give you an example, now I can't quote the exact numbers now, but I could quote what it was back then. In Seattle, everyone has to know CPR. If you take your driver's test, you have to do CPR. If you graduate from high school, CPR. If you have a house, you gotta learn CPR. And because of that, you had a 40% chance of walking out of the hospital if you went into cardiac arrest in Seattle. What was it in Cleveland?
I don't know.
1.8.
Wow.
1.8% chance that you would walk out of the hospital because no one knows CPR. And it's simple. It's just, I remember falling in love with it when I was an orderly. That was the orderly's job to do CPR, and it was cool. I liked doing it, especially when they came back. It was kind of incredible.
Yeah.
Amazing. Well, I think that's an important transition that we've seen, and people are much more aware nowadays, what to watch for. Many of us wear health monitors on our wrist to kind of keep track of our own physical.
Oh God, yeah. You have those little health monitors for AFib.
Mm-hmm.
Oh my God, they're fantastic. It's great.
Well, what other thoughts would you like to share with the history of medicine in the county, as we've heard from so many physicians and continue to do so for our exhibit next year? Is there any other thoughts you'd like to share about why people should come and learn about the history of medicine?
Oh, that's interesting. I was talking to my wife the other day about vaccines. There's all this argument about vaccines. And when I came out in 1990, when I came out of residency, whenever I worked the ER, there'd be, I'd see an epiglottitis a couple times a year.
Go ahead.
I'd see an epiglottitis a couple times a year. And on top of that, I would see meningitis often. I would see people with meningitis. So I was doing spinal taps, maybe 2 or 3 spinal taps a week when I was a younger physician. Well, when I retired by 2017, I'd be lucky to do 1 spinal tap a year. And I never saw, I don't know when was the last time I saw an epiglottitis. And why is that? Vaccines. Because of vaccines. That's the reason I never saw them.
That's an interesting comment, especially as you look back in history and the advent of vaccines for things like polio and so forth, and what impact that had on people's lives.
It really is.
Measles, mumps, rubella, all those things. So, well, it's been fantastic speaking with you, and you've given us some excellent ideas and concepts that we will be sharing in our exhibit. So on behalf of the Medina County Historical Society, we'd like to thank Dr. Kim Bowen for an excellent interview, and look forward to compiling all of these stories in a really neat video process next year. So thank you.
Oh, that's great. Yeah, and talk to, if you need anything from Nancy, any of those, you had mentioned something about Tom.
Yeah, Tom's video that he
Is Tom
did.
going to do a video
Yeah,
here too?
he was here last week.
Oh, cool.
Yeah, he talked, and it's amazing the similarity in your comments, which is what it's kind of a recurring theme that we'll probably build on, is how medicine has changed, and less face time with the patient has been the most common denominator, I think, of any of the.
I mean, he
comments.
didn't go through the hell of medical school.
You come on. Oh,
I wasn't sure if you.
I wasn't sure who it was. I heard somebody. Come on in. We're done. Yeah,
I'm just recording.
We're just signed off.
Extra.
This is my wife, Carol.
Hi.
Dr. Kim Bowen.
Hi.
He's excellent. I think your comments were spot on, and I think all the physicians you can share at lunch put a little of their egos in challenge. I say, if you haven't been here to share your thoughts, because these comments are going to be broadcast for quite a while in this.
Well, like I said about radiology, there's also been changes like neurology and heart attacks. If you had a heart attack when I was a younger doctor, I'd give you TPA, but the last thing I would do would be take you to a cath lab. We didn't do that.
Yeah.
No, the thought was if you took them to the heart's already irritated by having a heart attack. And if you took them to the cath lab, you'd kill them.
Wow.
So we never did any of that. So if you were having a stroke back then, now we go up and grab the clot and, oh my God, no, you're having a stroke. Family would just sit there and say, well, what's going to happen? I don't know. They may be able to walk again. They may be able to be paralyzed forever.
Wow. You don't have radiology on our list of specializations. Now, that doesn't mean that.
Do we have a
we don't, but he's going to the old Dawson. I would certainly think.
Round a couple up.
Yeah, put the word out.
Yeah, who was it? Greg Arco's been there for years, and
I don't know.
he
Are
you
those
don't
friends with Spicklers?
They may be.
Do you know Spicklers?
Don and Alice Spickler.
Who?
Don and Alice Spickler?
No.
He's not a doctor.
Jim and Jean and
No, different spicklers.
they're different Spicklers that I grew up next door to.
Oh, no, these grew up in West Virginia, so
And they live out in Johnny lives out in Brunswick.
I'm amazed how many people and even physicians have come from the Parma area. Must have been a
there's
huge
Tom.
brain drain in Parma because
Yeah.
they all moved to Medina.
Tulsiak's from Parma. Yeah, Tom's from Parma.
Yeah,
A lot of us.
yeah. He mentioned Tom and Terry grew up there,
We
and
grew up.
somebody else too. But we get a lot of guests from Parma that come to Medina. And
The only thing that I would ever add to this conversation is
turn back.
It's still rolling.
the Medina Hospital is very, very unique. It's very unique because it's so kind of isolated out there before we had using helicopters all the time and everything. And the doctors that took care of patients here really took care of their patients. I could tell you as an ER physician, I've worked maybe, 15 to maybe 20 different hospitals over my career. And the physicians I dealt with here at this hospital were remarkable. I mean, if I called them up and said, I need you now, they'd be there, without a doubt. And it's ironic because as an ER doctor here, and as a regular physician, you have to be really on top of your game. You have to be very good at what you do. The Jaysawals, the Warren Rose, the Rick Roses, you have to be Ebners, they all have to be excellent at what they do. And it's just it's a rare thing that we have. To give you an example, when we were a younger group, one of our doctors had moved away from the area, so I had to get a new doctor. And a doctor came to interview with our group, and our group was really special. We were just a small group, and if we had any money left over at the end of the year, we just split it up together. It was no big deal, you know. And this doctor came to me, and she had she was working down at Grant Hospital in Columbus, which is a trauma center. And she says, well, what happens if you get a bad trauma in? Who's your trauma doctor? And I said, well, you are. And she said, oh, well, what happens if you can't intubate the patient and put a tube in their throat? Who's your anesthesiologist? I said, well, if there's no anesthesists in-house, which they're not there all the time, I said, you do a crike. You open up the neck and put the tube in, you know. And she says, well, what happens if the patient's bleeding out and they've got a splenic rupture, and what do you do? And I said, well, you give O-negative blood and you call the helicopter and arrange for them to be transferred, but say a little prayer. That's about all you could do. Wow. And 2 days later, she called me. She says, there's no way I can work there.
Really?
She says, so she took a job over at Southwest, where they had much more support and you didn't have to be on your own.
We're fortunate of the physicians we've interviewed, and I'm sure there's younger ones still very active. I'm amazed at the level of care and compassion they all share. I mean, it is kind of, like you say, there are certain things you can do and certain things you can't do to save a patient, but it certainly sounds like we have a pretty good team of physicians in this county.
We really do. And one of the biggest positives and biggest negatives of being a doctor at Medina Hospital, the positives that there were times when someone would come in that maybe you knew the son or whatever, but you took care of their grandmother or whatever, and you were able to save them, as corny as that sounds. But then the negatives were the ones that died, and you knew them, and I remember, and I mentioned to you before, a physician and her daughter had died, and she saw my face and she knew exactly that her daughter had died. And it was just terrible. It was just terrible.
Well, doctors are certainly human and certainly have every emotion, but you manage to contain it scientifically as well as with the personal side, which I admire in our physicians. So,
we're very lucky. Medina, obviously you get a character or two. That's a different story. But as a whole, it was remarkable, and it made my job as an ER doc easy. I'll be honest with you. If I didn't feel comfortable with something, I didn't know what do I do next? I call the person up and they'd be there. And it's all about the patient. That's the neat thing about it.
Well, great. Well, thank you so much, Dr. Bowen. I think this has been a fantastic interview, and I'm looking forward to seeing all your comments, and it might be broken up a little as we answer certain questions, but I think you've given some great material to work with.
Yeah.
Great.
So thank you.
Thanks, guys.
Thank you so much.
I just want to thank you for starting the free clinic.
Oh, it's a good thing.
That's a great thing. That is a great thing.
Well, the reason I did it was because the ER, I'd see people in the ER and I'd be diagnosed, they had a stroke, they had a heart attack, they had belly pain, and I'd do a CT scan and find cancer. And the reason they're coming to the ER because we're the last thing, and they didn't have health care and they couldn't afford the medicines, And it's like, this system is wrong. It is just so wrong. So that's why I started the one in Parma in '95 and then came down here. And the people here, they always ask, talk to me about, I started it. I'll be honest with you, it's the people in Medina County that really support it.
Yeah.
And it really just, the people, and I mentioned to Brian before, I had mentioned when I moved down here from Parma, I turned to one of the docs and I said, these people all think they're special. You know, I said, are they that egotistic? You know, I mean, what the heck? And, you know, he was right. I mean, the people are right. The people in this community care about others. And I've never lived in a community that was so evident like this, you know, and that's cool.
That's interesting. That's a good thought to share, I think,
Yeah.
because you know, with all the talk in Washington to Columbus
Oh my
about
God.
medicine and, you know, cost of insurance, who's going to have insurance, who's going to win and lose in the insurance Medicaid arguments. I think it's wonderful that we have a free clinic. I'm sad that we need it because I think.
Oh, I keep on saying that I would love the day that I would have to close.
Yeah,
Yeah.
that would
We'd
be
have to
nice.
close it.
Medicine
That'd be cool.
or you know, medical coverage for all in some form or fashion that would be reasonable and affordable.
But the only negative, one of the negatives about doing that is that people would have to, in order for the government to be able to afford it, we would have to change our expectations. Like, you know, right now, you could have anything done to somebody that needs to be done medically. And they may put limitations on that as far as that's concerned. So, you know, if you're, like I said before, if you're 80-some years old and you have metastatic cancer, no, we're not gonna do any more. You know, we're just gonna let them go.
Mm-hmm.
So,
Understandable.
anyway.
Great. I think.
Dave's.
Well, welcome, Dr. Castele. Just like to ask a few questions, like what brought you to Medina and why did you bring your practice here?
Well, I went to Case Western Reserve University Medical School, and then we trained at Metro Health. It was Cuyahoga County Hospital back then, and then after that, I did a pulmonary and critical care training, you know, fellowship at Metro. And at that point, you have to make a decision on where you're going to go out into private practice. And there was a cardiologist, Terry Tulsiak, who had come down to Medina, and I knew him very well. He was a year ahead of me. And he asked if I'd come down, and I grew up in the Cleveland area, so I wanted to stay in this general area. Most of my family's here, but I didn't want to be that close to them. So Medina was a good place. I always, you know, liked the idea of practicing in a smaller town. And so Medina just worked out. It was a good place to be. It was close to where I grew up, but yet still had a small town flavor to it that I was interested in. And so we came down here in 1984.
What are some of your first memories of your practice here in Medina County? Did you cover the entire county or the city or just as needed?
We started a solo practice at the medical office building, which is next to the hospital. And I also did some consulting work at Wadsworth and also at Lodi, just because we were trying to build up a practice and get patients. And about half of what I did was inpatient care, and the other half were seeing patients in the office. So at Wadsworth and Lodi was mostly just doing inpatient care, and Medina was both inpatient and outpatient care. My first memories, you know, I trained in a huge hospital system, and coming down here, it was not that. It was a small facility, and you know, when you're in a specialty, you have other people working with you, but when you came down here, you were by yourself. So that was interesting for a while and challenging, but I think that was the first culture shock that I had to kind of get used to. So.
What changes at the county hospitals have made the biggest impression on you over your career?
The changes down here in Medina. Okay. Well, you know, when you first came here, there weren't a lot of medical specialists. There were some of the surgical specialties. There weren't a lot of medical specialists. And I was the only pulmonary physician that was down here at the beginning. And as time went on, that just gradually changed. And you had more medical specialists here. You had more surgical specialists that came. The technology definitely increased over time. The technology advances were incredible, really, when you think about it. In the time that I was practicing, it still is today, but even back then, it was, just huge. Things that we take for granted now was a lot of those things weren't available back then. So you had to use your other skills. But so those technological advancements were huge. Medical records advancements. Now you have electronic medical records. Back then, we just wrote everything down. I mean, it was a pen and a piece of paper, and you would write things down in your chart. And now that you have the technology such that you can share records, they're all electronic. People have access to their records. These are all things that I think have really changed in medicine, and down here too in Medina. The acts of seeing patients, so hasn't changed. That somebody coming to you for help and you trying to help them, that part of medicine hasn't changed, and hopefully it won't, but in the future. But so that's the basis, I think, of medicine. Most physicians, why they want to go into practice, to be honest with you.
What do you think is your most poignant memory of your practice, or persons or issues you've encountered?
Again, the most poignant were taking care of individual patients. I still remember, after all these years, some specific patients, and taking care of them and helping them with what their medical problems were. I mean, that's clearly the most poignant.
What do you think about medicine today that might sadden you a little bit?
I think, of course, when you get older and you retire, you always remember the old days. So, I'm not sure that it's that much different than it used to be, but I think we've depersonalized healthcare. Which I just told you, the most poignant memories are taking care of individual patients and remembering them. And I think that physician-patient relationship is eroding. And from all aspects, I don't think the physicians are trained to necessarily see people as their responsibility, now you're part of a big system, and you can have any of these 10 doctors can see you, and patients are, they likewise don't have the personal contact with their physician. They don't have that strong relationship. So I think that's what I would say, if you ask me what saddens me, that relationship that you have with people saddens me. And also relationship with other healthcare providers. Back when I first started practice, you knew all the other doctors, you knew their families. You would talk to them all the time about just what was going on in their lives. And we used to go down and talk to the radiologists, and we would see them in their offices and then talk to them and show them x-rays. And now the radiologist reading images may be in another continent somewhere. So you don't have those relationships. So I think the lack of relationships, or the loss of relationships, would sadden me the most.
So if you were to give advice to someone studying to be a physician and coming to this type of locale or county, what advice would you give that person?
I think that my advice would be to always try and remember why it is that you decided you wanted to go to medical school and wanted to be a physician. I always thought that, that you should be given your essay that you wrote when you had to write something to why you want to go to medical school and you're applying to medical school should always be given that every 5 years or so, and just be made to sit in some quiet, dark room and read it for 15 minutes and think about it. And so if you just remember what it is that you went into this for, would be my advice. You know, things are going to change and people are going to change. There's going to be problems, but people went into medicine for a reason, and that reason really shouldn't die. I mean, you should always think about that.
If you were to make a prediction for the future of medicine in our county, what might be thoughts that come to mind?
I think my prediction is that, you know, now we have big hospital systems, mostly Cleveland, but some Akron, you know, that are taking over healthcare. And I think there's a sense that they want to centralize that care into the bigger cities. And so the regional care is not going to be as important, you know, as it used to be. So that's just something that I see happening in the future, and it isn't necessarily a bad thing. You know, that you have technology at the bigger institutions and more resources. All right, but you know, people have to travel, so that's the drawback. So we just have to come up with a balance there, so we don't lose the small town flavor that really I think was what patients want.
Very good. Well, what other thoughts might you have or want to share in our exhibit about thoughts about medicine in general, of looking at the past, what you've done through and gone through, and what you would like people to know most about medicine in Medina County?
Well, I think, you know, showing how technology has changed over the years, I think would be very important. How healthcare is delivered would be very important. Things like showing I don't know how easily you could do this, but showing how, you know, medical records were kept back in the day and now how they are now, and how that technology has changed would be important. Just, if you don't mind, can I give you a short story? So I'm sure you'll hear the name Dr. Mansell, and he was still practicing, you know, when I was starting, and for a number of years. And anyway, when he was retiring, he said, I have this patient. He comes up to me. I have this patient that I've been seeing for like 50 years, and he had some lung problems, and he wanted me to take over his care. And I said, sure. And he goes, well, I'm going to give you his medical records. Now, you know, in like 5 visits, I would have, you know, stacks of records already, you know, and so I'm thinking, oh, 50 years, what? It's going to be like boxes and boxes of records, you know. And so the patient comes in with his records, and he reaches into his pocket and pulls out like 5 index cards. That's it. And it just, it had, you know, 1948 appendicitis. That's all it had, you know. There was nothing else. But, you know, it was basically just notes for him to know. And he knew everything about the patient, you know, and he knew what care he gave and things like that. So it's different today, obviously. So people, I guess, should understand that, and the technology, how that's advanced over time, I think would be important for people to know. I guess those would be the things that I would think you want to display. But you know, also the people. I mean, most of the physicians, when I practiced here, you know, lived in Medina. Their kids went to school in Medina, went to church in Medina, and you know, I think they were part of the community. And I'm not so sure that is so much anymore. But I think that people of today should, you know what it was like back then, and so that's something you might want to think about, kind of emphasizing in your exhibit.
That hit the nail right on the head. Yeah, exactly right. Are there any final thoughts you'd like to share about your career, and if it's possible to encourage people, as you've done, to get to know their doctor?
Yeah, you know, I would say that people haven't changed over the years. and their problems really haven't changed over the years, and their health issues really haven't changed over the years. And patients need to, look at to their doctors, and the doctors likewise have to look to their patients as, having strong relationships there, so that they can work together to take care of their health.
Very good.
Very good. Excellent.
I think that's good.
I believe, doctor, that you were the one that found the nodule on my lungs
I think I was.
14 years ago, and I will say that number one, it's still there. Number two,
Okay.
it hasn't grown.
Oh,
So
good.
I guess I believe your advice is watch it, and if it doesn't do anything, don't worry about it.
I think I remember what your X-ray looked like. I do. So
He had a big badge showing right here when he was wearing his police uniform. Well, thank you very much, Doctor.
Yeah,
It was
appreciate
wonderful.
it.
All of your our interviews have been so informative,
okay.
and there are some common threads certainly among them. But I
Sure.
also think you've each kind of zeroed in on certain aspects, which is what we were really hoping for.
Okay.
A variety. Before you're right, the patient-doctor relationship is good and bad. It's
Yeah,
still
I mean,
there, but
it's-
not in the form that you knew it.
No, it's just
and,
different. So, and you know what? I don't think that it's ever going to go back. But I don't. It's not characteristic of this community. It's like it's
Everywhere.
nationwide.
Yeah.
It's just the way that it is, and the way it goes. But I think what it's not just with healthcare. It's with your.
Sure.
It's with the schools, your
Your
bank,
car mechanic, any
car mechanic.
yeah.
It's with everything.
Mhm.
So, and that's too bad. So,
I think it's interesting when you put all these together. It's almost like this is a particular view, this is a particular view, but centrally is that it's
Yeah.
a change from a personal relationship with the patient
yeah,
and the doctors to now sort of technology takes over rather than the
Mhm.
history and getting
Yeah.
to really know the patient.
yeah,
And been kind of a common theme throughout the whole series of interviews that we had.
yeah.
And
I used to tell that, like, when I would be teach some residents or something or whatever, that with every patient, there's something in that patient that is in common with you. As different as it may seem that this person is, there's something in their life that's in common with you, and you need to try and find out what that is. And once you have that and you understand it, it'll be a strong bond that'll be
Mhm.
very, very important. But I don't know that people take the time or the effort
No.
to do that, to find that out. But
when I shared too, we used to have the old charts that were on the room where you were going to go in
Yeah.
and pick it up.
yeah,
I'd lift everything up, and on the inside of the chart, I had written things about them. The thing about
Yeah.
them, we had
yeah,
we motorhome together. We did this,
Yeah.
or you had a dog named so and so, or you had this,
right,
and then you could pick that up, even if you couldn't really remember all the details. You'd written it down. You could go in and walk in and say, "Have you taken any motorhome trips lately?" and everything, and then the patient's eyes kind of lit up.
Oh yeah,
because they said we've got something together, not just okay. You're a number. I'm going to write down.
yeah. It humanizes.
Yeah, humanizes.
It really does. So,
Yeah.
but
Unfortunately, we've lost a lot of that.
yeah,
Well, I think you're dead on. And what we hope for with this exhibit is that we can bring a little closer relationship to medicine as it was practiced for many, many years, and
Mhm.
still the vital link is between you and your doctor
Yeah.
more than anything.
right.
So
All right.
you're done for the day.
Thank
All
you.
right.
Appreciate
Well,
it.
thanks. I hope that helps. Hear something, or if they had pneumonia, you would hear things. I mean, the physical exam was a lot more important back then, 100 years ago. But until you had X-rays, so you could really see what was going on and start evaluating people. There was a limit to what you can do, and that was before therapies were available. So, I mean, it's obviously just a slow progression over time, but technology advances on itself, so we can do more and more now. So,
Pretty interesting.
yeah, it is. So,
When we read old history volumes of ailments, and
Yeah.
read the old ads in the newspapers 100 years ago. There was a cure-all for about everything.
Yeah. Oh, yeah. Right.
You know,
So,
mostly alcohol, probably.
Yeah.
But, you know,
well, there still is.
yeah.
The TV, if you watch the
I mean,
ads on TV, it's,
Unbelievable. Yeah, I mean,
Yeah.
it's just 20 minutes of medical commercials every single
Yeah.
night. I said, come on. You know, you could have had the weather forecast done 10 minutes ago, but you space it all out. But, you know, but that's how people are getting their information, right or wrong.
Yeah, right.
I'm sure they come to physicians nowadays saying, I saw this on TV.
Oh, well, yeah.
Oh, yeah.
And what are you going to do about it? You know?
Yeah, right. Well, the patients are much more educated, obviously. They're very, very educated. And so they come with questions that you better be ready to answer. And that's not a bad thing, but it's, you know, when we train, you just basically told people what to do. They barely asked questions. And that was it. But nowadays you can't do that anymore. So yeah, you better know what's going on. So,
The internet's a powerful tool, but and even in the columns in the newspaper, because that and Deacon both have a medical. And actually, some of it looks pretty reasonable when people give their symptoms and the doctor tries to figure out is that right or wrong. But
well, and there's so much confusion. I mean, not trying to be political, but if you just look about what's on the news about vaccines or medications or whatever, I mean, it's so confusing, and the average person, you know, it confuses them. You don't know what to do, who to believe, you know, and it's not a good thing sometimes.
Is that like whooping cough would have been up your alley in its day?
Probably not. I mean, that would be more like for pediatric patients, but whooping cough wouldn't have been a big thing. We had a lot of patients with tuberculosis, and you know, of course, when I was growing up, you know, everybody had infectious diseases, chickenpox, measles, mumps, you know, we all had them. So my granddaughter, she's 2, when she was about 9 months old, she had this rash. And, you know, they're sending us pictures, you know, and FaceTiming, and I can look at this rash. I go, what's this rash? I'm looking at it, she had chickenpox. But they didn't know what her parents, my son and his wife didn't know what it was. And I said, well, I think she's got chickenpox. You got to take her to the pediatrician, I guess. And the pediatricians never had seen a case of chickenpox, and you know, and wasn't really sure what to do. And she would have gotten the vaccine, but you know, she wasn't old enough to get the vaccine yet. So she ended up getting chickenpox before she could get the vaccine. And but so the healthcare providers had never seen it. It's like a rare case. Can you imagine that?
I'm Kristen Dawson. I'm a general surgeon at Medina Hospital. I actually grew up in Medina and went off to do my schooling. And then I came back to Medina in 2001 to join staff. And I've been there ever since. Actually, this is my only job that I've had. So It's been phenomenal.
Yes, and so we do ask, you know, why Medina Hospital over other area hospitals?
Honestly, the biggest thing was the fact that I grew up here and my dad was an orthopedic surgeon here for 30 years. And that really was probably the impetus for me to come back and work here. I looked at other places, but I am so glad that I chose Medina. It's just been such a great place to raise my family and to practice. So, and
Absolutely.
fantastic partners that I joined here at Medina, and it was fantastic.
So you've been with Medina for quite a while. What changes have you seen at Medina Hospital in the years that you've been practicing?
So the biggest change by far has been obviously the Cleveland Clinic coming in and joining with the hospital and bringing a lot of changes, which honestly they've been, you know, good and bad and struggles, but they've overall I would say has been a great addition to the hospital. They brought a lot of resources, a lot of expertise to the hospital that we didn't have before. And I think it's been a good change that we've had to weather through, but now we've been with them for 15, 16 years. So it's been good.
Good. And as a general surgeon, you have, I'm sure, seen changes in your specialty over the years. Are there any changes that are um, either you really do appreciate or maybe see as not such a good change?
I would say the biggest change with general surgery has been the minimally invasive procedures that we're now able to do, which in my training back in the 90s and early 2000s, that was just on the cusp of things happening in general surgery as far as the minimally invasive laparoscopic surgeries, doing less surgery for certain things, especially like breast cancer. We're not doing as much surgery, not as indicated. So I think that's probably been the biggest change, has just been faster recoveries and less pain.
So, also, just in medicine in general, what changes have you witnessed?
Several. I would say the biggest change that I've been most appreciative of has been just the advances in oncology and the kind of rheumatoid type diseases with chronic inflammation and things like that, where we've learned how to, with medications, we've learned how to manipulate our immune system to help fight cancer, to help minimize inflammation, things like that, to help with those kind of diseases. That's been pretty phenomenal in the setting of oncology. As far as other things, AI, that's kind of been a newer addition to our practice for the past year, almost a year. Huge game changer for us from a surgical or from a patient care standpoint. Just getting our notes done, being able to sit down with a patient and be able to have a conversation with them without having to be on a computer. A lot of it is just being recorded, and then you're just helping with your notes. It's not taking the place of my job, but it's just certainly making my job much, much easier.
Perfect. We've had the discussion about AI with many.
Mm-hmm.
Are there any concerns that AI brings to your specialty or to medicine in general?
I would say if you're using it to replace the human aspect of it, that's where it's going to go wrong. Because even in our notes, it doesn't always get it right. You absolutely have to review it and make sure that everything in there is what happened and what was said, and there's no extraneous things coming in. So it does not take the place of the human factor at all.
Good. I know that you've had many interactions with patients. Are there any that have a poignant or significant memory with any particular instance with a patient?
I would say that the ones that I've taken care of on a long-term basis, that's not something most general surgeons get a chance to do. It's a lot of, you come in, you're sick, we help you feel better, and then you move on. But I would say the patients that have stuck with me the most have been, a lot of my breast cancer patients, colon cancer patients that I see for years and years and have developed a relationship with. I've taken care of their kids. So it's been, I would say that those are the patients that stick out in my mind the most.
So we've talked a little bit about changes. Is there something that you would think or you would call out as the best change, either in your specialty or in medicine, or even at the hospital?
I would say, for sure at the hospital, the changes that have occurred have been, for the most part, very positive. We have, a fantastic staff. The administration, the mid-levels, everyone that works there has just been so fantastic to work with. And I feel that camaraderie at the hospital has really progressed, especially over the past 5-7 years, getting through COVID together, doing, a lot of, tough things together. It has been probably the best that's happened at Medina Hospital over the years.
So we've talked a lot about positive changes. Is there any change that has saddened you over the years?
I would say that the biggest challenge has been how many patients that we take care of now and how sick they are. And it's sad in the sense that, our ERs are just overwhelmed. It's so hard to get patients into the hospital because it's so full. But it's a challenge that I think that Medina Hospital will be able to meet, and hopefully expand our services, be able to help more patients, because it's not going anywhere. we're always going to be full.
I
So
think so. That's so true. So you've been in practice for a while, and you're a woman general surgeon. What advice would you give to either new practice in practice, or even thinking about becoming maybe a woman in medicine, or just medicine in general? What kind of advice would you give?
I think the best advice, and I probably learned this from my father without him even realizing it, is to really just treat your patients like their family and take care of them like you would want someone to take care of you. If you're a female looking to go into the medical field, don't shy away from the hard work, because it's worth it. It's so rewarding to, see your patients after you've taken care of them, either in the hospital or at the grocery store, and having that that connection with them has just been just amazing.
So nice to hear. So talking about the future, what kinds of future changes do you see either in your specialty or in medicine in general?
I think AI is going to probably, don't ask me any specifics about it. I'm not that's not my field, but I think that's going to help medicine in general, probably the most. In surgery, there's a lot more robotic surgery happening, which, from an old person standpoint, I guess it's kind of hard for me to move in that direction, but the ergonomics are helpful for us as we get older, not having to stand for long periods of time. Things like that are certainly beneficial, different than what I trained with, but I think would be a positive. So I would say robotics and AI are probably the two big things in surgery.
Great. Thank you so much. So in summary, are there any other thoughts that you would like to share with the community or with those who will be participating in our exhibit?
I would say that I have been so blessed to be working in this community, in this job, fantastic partners, being able to work with my dad for 5 years. I mean, it's been just a fantastic opportunity to not only work at Medina Hospital, but to also, again, raise my family here. They actually all went to the same schools that I did and have almost all graduated. But it's just been a great experience for me.
Perfect. And speaking from personal experience, it's been a great opportunity to actually have worked with you as well.
Yeah, and you too.
Any other comments or questions? Any other thoughts? All right. Thank you so much, Dr. Dawson.
Thank you. I appreciate the opportunity.
Thank you.
Right.
Okay, what are some of your first memories of practice in Medina County?
Well, I like the smallness of it. I trained in Columbus, and it's a big metropolitan area, but I like Medina. I was about 2 minutes from the hospital, and it was a beautiful little town. And we had, as I said, 4 kids when we moved here, and we thought it'd be a great place to raise a family. And so it has been. But I think when we came here, we thought this sleepy little town, we'll live here and I'll practice here, but we'll probably do all our social stuff in Cleveland. And I don't think we ever did go to Cleveland. and we became, Joyce's pretty social person, and we got to know a lot of people in town and the hospital. I think most of our friends initially were doctors, but we soon met other friends in the neighborhood and became very close friends. And kids went to God, I'm getting old. My memory fades me. The elementary school over on Union Street by the
Sydney Fenn.
Sydney Fenn. Thanks. I'm going to ask you probably a few more memory questions. Kids went to Sydney Fenn and then to Medina High School, and I think they got a great education. We're very happy with how that all turned out in Medina.
Okay. When it comes to changes at the hospital, what made the biggest impression on you?
Well, I think they were, when I came, it was the little house and then the first building. And Ed Hall was the administrator there, and he was open to suggestions. Ed liked to talk, so you didn't go into his office unless you had a half hour to be there. And but I thought he was a very good administrator. And there was a lot of changes in orthopedics occurring then. We had the development of a portable X-ray, a C-arm, which in orthopedics, a lot of our work was with hip fractures and stuff, and that revolutionized how you did a hip fracture. And the hospital, was very quick to add that because we told them how bad we needed it. Plus arthroscopy. Arthroscopy is the use of small instruments to look inside the knee or the shoulder, mostly the knee, and you can make a clinical diagnosis through a history and physical, have some idea about what's going on. But arthroscopy initially was to help your diagnostic ability to look inside and see what it was, and then you'd open them up. Well, pretty soon they came out with arthroscopic instruments, and you could work inside the knee without making a big incision. So that was revolutionary. That was one of the best. In my career, it was probably one of the best advancements we had. That and the X-ray, the C-arm, where you could see where your metal pins were going without bringing in X-rays and get them developed. It was a very forward. There's been a lot of changes in orthopedics since I moved here, and just adapt, try the new stuff, and apply it, and that was generally almost always for the better. Let me grab my paper.
Expanding on that, what would you think would be the best change that you have seen in medicine today?
In medicine?
Mm-hmm.
Well, in orthopedics, the biggest change was probably the portable X-ray and fluoroscopy and the arthroscopy. That revolutionized how we could take care of orthopedic problems. And what was developed about the same time I came here was the total joint replacements, hips and knees. And there were a lot of people with arthritis who suffered, when all we had before them was anti-inflammatory medications, which did a good job if they weren't if it wasn't advanced arthritis, but it got to the point where that joints were so destroyed by the arthritis that you had to replace them with the joint replacements. And that was pretty much in its infancy when I first came. And that's been amazing the way that's developed, and takes people who were essentially confined to wheelchairs because they had arthritic hips or knees and they couldn't get around, to allow them to be mobile.
Is there a change in medicine today that saddens you the most?
A change in medicine? Yeah, I think it's probably not so much the physical aspects of medicine, but the how do I say this? The business of medicine. When I first came, doctors had their own private practice. That's rare now. They work for the Cleveland Clinic or Summa, and very few independent practitioners now. I think basically you can be in a Cleveland Clinic situation, still practice good medicine. My daughter is a general surgeon in town here, and she loves taking care of people, and she doesn't seem to bother her that much that she's working for the Cleveland Clinic. But when I was in practice, everybody had their own practice and their own responsibility to the patient.
What would be the best advice that you could give other physicians practicing today?
Well, I've been away from it for about 10 years. I don't know, just the patient comes first, and have good rapport with the patient, treat them as people, not a problem. And it really depends on your attitude towards people. I mean, that isn't something you can develop by going to med school. Mm-hmm. And stay up with the current trends and what's working better. Being willing to change what you're doing for the better.
Are there any other thoughts?
Any other thoughts?
Any other thoughts on any of the practices of medicine or anything from your field?
Well, I really enjoyed medicine. I'm so blessed being able to get into that. And I have 2 children who are doctors, and they both love it. And it's science, but it's also the art of medicine. I mean, I enjoyed, actually, most surgeons would rather be in the operating room than in the office. And actually, I really enjoyed the office. Maybe I'm just a talker, I don't know, but I always enjoyed that part of it. And I don't know, I'm just feel blessed that I was able to do it and to be in Medina. Great place to live and raise a family.
Well, Dr. Ebner, I think you've been involved in some international work. Have you gone to other countries?
Yes, I have.
Why do you think that's related to your practice?
Well, when my wife died about 20 years ago, and I always wanted to go to Africa, generally, to practice someday. It was just a pipe dream. I didn't know if it was ever going to happen or not. But when she passed, the opportunity was to just go. And I started, I can't remember when it was, 1970, I think. Or no, 70, 2027, 2010. I got in touch with Franklin Graham's unit about serving in helping the medical missionaries in different places, and I talked to them, and they said, "Oh, sure, we could always use orthopods." So I started going to Kenya, a place called Tenwick Hospital in Kenya, which is probably most people don't know the map of Kenya, but Nairobi is kind of central. That's the capital. And then about 4-hour drive from there is a little mission hospital, which was doing orthopedics. And I started going there, and I was there about a dozen times, usually 4 to 6 weeks, and I just loved it. It was practicing medicine without all the concerns we have about insurance and everything else. It was just taking care of people, and I saw some very interesting things there, and but a lot of it was the same sort of stuff you see here: sore shoulders, fractures. They had this little hospital, was about the size of Medina Hospital, and had the missionary doctors really kept it up to date. They had a C-arm where we could see fractures, take care of fractures, and very good instruments there. And lot of stuff donated to them from hospitals in the States. But the people were very appreciative of being taken care of. Yeah, I saw some interesting things there. One was a little girl who, in Africa, the kids go down in the morning to get buckets of water for the family down to the river, and also in the hippopotami who live in the river, usually at night go up and forage. They eat grass, but then when the sun starts coming up, they want to get back to the water. This little girl I saw was carrying the water up to the family, and just happened to come face to face with the hippopotamus, and he attacked her and grabbed her by the arm and threw her up in the air. Fortunately, he didn't grab her chest or her abdomen. She wouldn't be alive, but she came in with about 4 or 5 fractures around her elbow, but everything went back together real well. Because I wasn't there going to be there very long, see her in follow-up, but she came on the back of a motorcycle, probably rode 4 hours. They don't have ambulances over there, and you get to the hospital as best you can. And but anyway, she was very stoic. But I never saw a hippo attack in Medina.
Wow, that would be a very interesting experience. I was just going to ask what things you learned there that you could have brought back here, and it sounds like dodging hippos would be one of those.
No, it was pretty much the same stuff we see. Fractures are fractures, and they had very good instrumentation. It's just sometimes the way they happened was different than what you see here. I had a man came in with an arrow sticking out of the back of his neck. It didn't hit his spinal cord or anything. It just stuck in the bones of the spine around his neck. He was stealing stuff out of somebody's garden, and they don't have a police force over there, and so it's kind of you take care of yourself. And whoever shot him did a pretty good job. But it didn't hit anything serious. He had a little numbness in one of his arms, but he could still walk, and it was kind of strange seeing him walking around with an arrow sticking out of his neck. But it came out. We had to operate on him to get it out, but didn't have to do much more than that.
If you were around in the early days of Medina County, let's say 1820, 1830, and someone broke their leg or broke their arm, what would have been the treatment, you think, as best you might guess? How would they have done what you just did today?
They would have splintered it. They would have put a towel or something around it and put metal or wood boards down each side and then wrap a rag around it to hold it in place, immobilize it. That's the main thing. And I'm not sure when plaster casts first came out. It must have been around the turn of the century, 1800s, 1900s. And that really revolutionized how you could take care of them. And eventually they came out with plastic casts, which we have nowadays, where you can get them wet. So the kid with a broken arm who went to the seashore could go into the water with these, where before you get the plaster casts wet, they fall apart.
Interesting. Well, I think we appreciate your feedback and your comments. It's been very interesting. Any final thoughts you'd like to share, or trying to tell the community how medicine has changed, and certainly your role has changed as many of the physicians we've interviewed. Any other final thoughts? You glad things aren't the way they used to be?
Well, I'm glad the way they are now than the way they used to be as far as practicing medicine is concerned. What was the question again? Any
final thoughts as to medicine before versus today, and
well, it's all been medicine today is all for the better. The surgeries are becoming a lot of them became smaller incisions, and doing stuff with instruments that weren't available 30, 40 years ago. And that's been revolutionary, I think, as far as getting people up and getting them going. You know, when you make a big incision, like to do a total hip or something like that, that incision carries some morbidity with it. You know, it takes a while for that soft tissue to heal. Now we're doing it under much smaller incisions or do it with arthroscopically, and people can get up, heal much quicker, and get up and get going.
Morning,
Good
Dr.
morning.
Farnham. So to begin with, why don't you just kind of talk about, why and how you ended up in Medina, some of your favorite memories of Medina, practicing in Medina, and then, just a little bit about your background.
Okay, came here in Medina in 1963 with a wife and 2 kids. I was a graduate from the College of Medicine, Ohio State University, and I spent 5 years at Riverside Hospital in Columbus, Ohio. Altogether, I spent 9 years in Columbus, loved it dearly, enjoyed the football team and going to the sport games and all that sort. But there wasn't much chance of practicing medicine in Columbus as a newbie, as I would say. You had Mount Carmel Hospital putting out doctors, residents. You had Grant Hospital, Ohio State University, and of course, Riverside Methodist. So you got a wife, 2 kids, no money, and guess what? You have to go to work. We looked around at several places in Ohio, and most of those places, there'd been a senior doctor there, and he'd want you to start in as an employee. I did not want to be an employee. I wanted to be a part-time to a full-time partner, earning my way as we go. So interestingly enough, my father-in-law was a friend of Gene Austin here in town, and suggested I come look at Medina. Well, being a typical male, who's going to pay any attention to father-in-law or mother-in-law? You know, I'm independent-minded on that. Well, we did come up here and enjoyed Gene Austin, a very fine gentleman. His wife was a lovely person. And he thought, I ought to see William Dwyer, Bill Dwyer, a general surgeon who trained at Mayo Clinic. And so I came out and talked to Bill and came up a couple of times to help him in surgery as assistant and see what happened at the hospital here and so forth and so on. And people were nice. He offered me a good situation where we could become full partners in a period of time and not an employee. And that suited what I wanted to do and so forth and so on. Now, when we got started at the hospital, you go from a training situation to a community hospital, and things needed to be changed somewhat. And you're thinking, these were days when Lynn Mansell would use drop ether to put patients asleep and so forth and so on, which is fine. It worked out very good. I remember when I had drop ether, when I had a surgery procedure done, and I felt like people were pulling me apart while I'm asleep and so forth and so on. It all worked out fine. And but you knew things had to change. And Gene Austin had said, this is going to be an area of growth. People are going to be coming in. The community was expanding, a wonderful community. You had churches here, friendly people here. And I remembered Gene Cook was a good person. And in 63, there were very few rental properties here in Medina whatsoever. But Gene found a place, and we had a good time over on Parkview Avenue where several other people were in our age. A couple other doctors lived in that block. And so we had a good time. But looking at the hospital, we really needed to move forward in the situation. And I think, in my opinion, we had some people on the board that maybe didn't want to move too fast. I don't know what you guys thought about it at the time. But then I think we tried to get something going, and Bill and I, and Amos Mears came to town. Then Robertson and Roy Miller came to town and kind of got the ball rolling, got some new members in the board of trustees, and things got to move. And now you look at the hospital we have now. I mean, it's fantastic. When you look at that lamp here, you didn't have the fancy equipment that you have today. And it's amazing to me, the changes between 1963 and now. It's just fantastic, the changes that have taken place.
So we have talked a little bit about the changes. And so what major changes have you seen in your specialty?
Oh, okay. I would say the biggest change that I see today is laparoscopic surgery. I had gone to the American College of Surgery convention, I think in Atlanta, Georgia or someplace, and they showed a movie of a videotape of doing gallbladder surgery where you take the gallbladder out just through an instrument through your belly button and a couple other small incisions, done in a short period of time, safely, and under general anesthesia, obviously. But I think that was the biggest thing. Now, that was in 1989. We went away. We were in a group of 3 at that time. We went away for individual training to learn how to do this procedure. So we went down to, I think it was Cincinnati Hospital down there, the training hospital, learned how to do this laparoscopic surgery. So then there's an old saying, I think Ochsner from the clinic down in New Orleans says that something about don't be the last to give up an old procedure, nor the first to start a new one. Well, when you saw the videotape and how amazing it was to see that being done, so after learning the training, we wanted to start out with good, healthy patients. We wanted the procedure to work out nicely and everything. So now we did some on healthy patients, and you'd advance to sicker and sicker patients. And the point being now, for example, I came in the hospital at 7 o'clock one morning, had my gallbladder taken out at 8 o'clock, and I was home at 12 noon. Before, we'd admit the patient the night before. They would be having surgery, and then they'd stay for a week afterwards. Now, it's much better to get patients back doing what they were doing ahead of surgery, after surgery, lesser expense, lesser pain, and much safer. Now, today you see people, which I wasn't trained for, but now the group that we originated, they're doing colon resections, taking out a part of colon and hooking it up under the laparoscope, and many other procedures that we never even thought about. So that, to me, in general surgery is one of the really important things that are helping patients. It's safer, cheaper, and more efficient all the way along.
So, and then what are some of your thoughts about major changes in medicine in general?
We were talking about this. Somebody suggested, what were we doing back in 63 we're not doing today? And I spent a long time thinking about it, and I'm thinking, I don't know. But one of the things that came to mind are house calls. Now, even in general surgery, I would make house calls. Not often. I mean, how am I going to do surgery in patients' home? Let's face it, those days are long, long gone. But I think that's one of the things that I look at. And I don't know whether they make house calls anymore or not. It's a whole new ball game. I would say most of them do not. That's one of the big things.
Do you have any really poignant memories of an issue, a patient, something you've done in your practice?
Oh my, that's a tough one. I think of some of the funny ones that happened. I remember being called down to the emergency room. They said, Doc Farnham, you got to get down to the emergency room right away. We got a guy here. Okay, I go down there, and the guy says, I just shot something. I said, oh. So he led me out to his car, and he raises the trunk lid of his car, and there's his favorite dog, hunting dog. he had shot the dog accidentally. And I thought, heck, God, I'm not a veterinarian, but I got my stethoscope out, listened to the dog and everything. I said, man, I'm sorry. This dog is gone. So there's some of the things that happen. The serious things that happen and you wonder about is I remember a child being in a motor car accident. We didn't have any blood at the hospital at the time. And this boy was pretty seriously injured with an intra-abdominal injury, so didn't want to do it at the hospital here without blood being available. And we shipped him right away to Akron Children's. And he looked up at me and he said, am I going to die? I thought, oh my God. He did. That hurt. It always hurts bad. Go ahead.
All right. Well, thank you so much for sharing that. We appreciate that. So, what would be your best advice to physicians coming into practice today?
What bothers me so much about seeing these, they're going to be employees. The private practice is basically gone here in Medina. I was not cut out to be an employee, and it's a whole new ball game. But by the same token, I'm a graduate of Mount Union over in Alliance, Ohio, which is a different story. But when you go over and talk to the students that are entering pre-med, and sometimes we are asked to join a group like this to talk to the pre-med students, and I say, man, I started out here and look where we are today. You're starting out here. Look where you're going to be in 10 years. Don't think of what you're seeing today. Think of what you've got 10 years, 20 years down the road. When you see the progress that we've made over the years, it's going to be amazing what the future is going to hold. But you've got to learn. You've got to stay current. We had to go back to learn training in ultrasound, localization for breast surgery, of needle aspirations, all sorts of chemotherapy situations, and so forth and so on. You're going to have to do the same thing. The training you're getting today isn't going to work perhaps 10, 15 years down the road. You've got to keep up. You've got to keep on top of things, and no changes are going to occur, and you're going to have to adapt to them. Otherwise, you're going to be left behind.
So, since you've mentioned changes, so what would you see as the future of medicine in both medicine in general and in Medina County?
Well, I think we've done a pretty good job, and it's continuing. I think there's very excellent care, but by the same token, there are some limitations to what can be done here. We don't do brain surgery. We don't do heart surgery and some of those other things which have to go to the main centers and so forth. But I think the group here has kept up the pace pretty doggone well and provide a very good level of surgery here at Medina Hospital.
Well, that's great to hear. So, excuse me. So, what final thoughts might you have that you'd like to share with the group? Something that would benefit either future doctors or just the general public in terms of other thoughts that you might have?
Well, I think that the public here can have confidence in the physicians. What I don't like is the politicization of medicine any more than I hate the politicization of so many things. I think of how they lied to us about the government, lied to us about the COVID situation and a few other things. But in general, I think that we can look forward to further progress. I think back to when we used to remove stomachs for ulcers, bleeding ulcers, and things like that. Now, instead of taking a stomach out or doing surgery on a stomach, you take a pill a couple times a day. This is going to happen again in the future. Take a pill to cure a cancer, do something else. This is going to be in the future coming down the line. And we got to be prepared for it, accept it, like I say, don't be the first to start a brand new procedure until it's a little bit proven, but don't be the last to drop an old item along the way.
Any other thoughts?
Oh, can't think of any right now.
Thank you so much for your time, Dr. Farnham.
Yeah. Well, something else I think ought to be mentioned. I don't know whether you guys talked about it, but I think one of the things that we ought to really give some thought to, it's the fact that Ed Hall came to the hospital at a great time. And remember, we used to have to go from 750 East Washington, the office building, run down to when we had to cover the emergency room, run down to the hospital, and we said, why don't we build a office center next to the hospital so you don't have to be running back and forth to the emergency room to cover the emergency room. Now today, I don't think, well, they have particular people that run the emergency room now, whereas we had to cover it in my day, for Pete's sakes. So that's one of the big things. I think Ed Hall should deserve some kudos for what he did, bringing a fresh air to the administration of this hospital.
Well said.
Anything else? I got a lot of things marked down here. And I think back to the old days. Remember when Dick Gross came he came about the same time, about 63, 64. And I'd have to call him into the emergency room when we had a non-mobile accident to read the x-rays because he was the expert at it, not I. And he'd come over dressed like I am in the middle of winter. And I said, Dick, what the heck is wrong with you? It's cold here. He said, Ed, have you ever lived in Fargo, North Dakota? And I said, no, now I understand it and everything. But I thought the guy was nuts. And then it was funny because Bob Winter lived down in Westfield Center. And I'd have to call him sometimes at 3 o'clock in the morning, come up and read x-rays. Well, he'd get in his sports car. He got picked up more than once by the patrol because he was speeding to get up to read and so forth and so on. And those are some funny times that we had going on. Shooting in the emergency room. I mean, people coming in bashed up at automobile accidents. But those are some good days. Talking about, remember when Carson would get in with your partner,
Miller, yeah.
huh?
Right, Miller.
Roy, about parking in the emergency room and things like that. Oh gosh. Oh, thinking back to some of those things. I wrote a whole bunch of things down. Well, I think one of the things, you knew people at the hospital. You knew the guy that cleaned the floors, the maintenance people, the x-ray people, the x-ray technicians, lab technicians. You saw them. Today, I don't know whether this is still going on, but we have what I call circuit rider doctors. How many of today's doctors live in town? I don't know. But living in town is a different thing than living in Cleveland and operating on somebody. You operate on somebody, you see them at church. If you're doing the front yard, patient would stop by, you talk to them, how are things going? Whether there's personal, it would be like more of a family. You knew what nurse you were operating with, who the technicians were, who you could trust, who you couldn't trust. Today, the doctors tell me they don't know what nurse they're having, when, and where. Now, this is from them. I don't really know exactly what's happening, but I want to know what nurse I'm working with. And now, the other thing would be is the malpractice situation. There had been a period of time where we really had a malpractice situation here in town. Everybody I had one lawyer come up to me and say, can you find a case that I can do for malpractice? And I thought, hell no, I'm not going to do that. I mean, everybody's trying to do the best they can, and things don't always go all right. stuff happens, and patients are sometimes in real bad shape and may not make it, so forth and so on. Today, that's a different ball game, but it was more like a family situation. I remember calling Lynn Mast up. I said, Lynn, you better come up in the emergency room. I had examined this guy. He had a little cut in the retina. Yeah, it would be the retina was hanging out from a small cut in the eye. I said, I can't do that. Get your butt in here and get it taken care of. Or if things like that happen. And today, I don't know. We don't have some of these guys. They're circuit riders. They don't live in town. Not that they're bad doctors or anything. Like my cardiologist was living in Worcester. Well, that's fine, but who do I go to? And they said, well, you better go to the emergency room and then they'll find you somebody. Well, I kind of like to have a cardiologist in town. Things are a little different. And we're going to have a meeting next week where a lot of retirees from the hospital, whether they're x-ray techs, lab techs, or doctors, nurses, everything, meet at a church in Valley City. Or it's going to be Brunswick this year. Yeah. I bet you when us guys are all gone, I doubt this is going to happen again. It's a new thing. And it's corporate medicine, as I call it. And I'm not so sure that's the way to go. I think the personal taking care of somebody, when you trust your family doctor, when you trust your surgeon or your OB man. I look back, there used to be 350 babies delivered in Medina Hospital per year. There are no deliveries in Medina County, a county of 165, maybe 170,000 people. Nobody. You have to go somewhere else. Well, what if you're in distress? Well, they can take care of you in the emergency room. That's not the way to do it, guys. I don't like that part of it. And, well, Denny, didn't you deliver babies?
Oh, sure.
I mean,
Lots of them.
Yeah.
They suddenly told me my insurance was going to go up to 100,000.
Yeah.
I continue delivering babies.
Yeah.
I said, I'm only getting $900. I can't afford that.
I mean, it is a business. You gotta pay your dues and you gotta feed your family, You still gotta make a living.
So we've heard that a lot. So when you talk to younger doctors, maybe not the brand new ones, but they've been in practice 5 years, 10 years, what is their sense of how satisfied they are, or do they have that same sense of loss in terms of getting
I don't
family
think so.
oriented? No.
But I had some work done not too long ago, and a female surgeon. I mean, not that I care, male, female. My partner was Chinese, good guy. He operated on me. I don't care. I care about competency. Are you trained well? Are you ethical? Are you doing a good job? Or at least trying to do an excellent job? The person that I had, they're accepting it because they didn't start out here. They're starting here. And it's a different ball game when you enter into the practice today, or the corporate practice, as I call it. You're accepting of that. And it's a different ball game from 1963 to 2000. And I think the kids today accept it more than I would have and did, period. Yeah.
Do you think they missed something in the...
Yeah, I do. Yeah. And like I say, how many of them are going to make a house call? I don't know. You go into their home, you see their family and stuff like that, you know what's going on. You see them in church, you see them out walking around different places. It's different. And if you're not brought up that way, you can't miss something you haven't hit. Any other question?
Do you have any other things on your sheet you want to share?
Let me see. Oh, I don't know. I ranted and raved. Let's see. Oh, one thing I got a kick out of when I first started here, and they call in. Oh, that's another thing that I can't get over. You can't call into the doctor's office anymore. You got to call into some center and God knows where, and they'll tell you when. Well, my name was in the phone book when they had phone books. You could stop by my house. My phone number was listed there. My address was listed there. It isn't that way today. But I still remember back in '63, the phone company, you had a 3-limit cutoff. And you'd be talking to a patient and you'd be talking as fast as you can, then the cutoff would happen. And so you'd run to the patient in the office and take care of them. And it was terrible. But then you had to pull strings to get a private phone into your home in case you had to run into the emergency room. And thank God I knew somebody that and I was able to get a private phone. Otherwise, how can you practice and cover the emergency room and not have a private phone in your house? Those things like that are just, when you look back on it, are kind of funny in a way. People can't believe you had a 3-minute cutoff. I remember even when we had hall beds before the new hospital was built, we had beds in the hall with screens around them, trying to take care of them and stuff like that. And you look at today, you go into an operating room, it's just utterly amazing, the equipment they have, the videotaping, everything. It just, you got to keep up. And I think Medina Hospital has done a pretty good job for a general community hospital. Really, I had to. And all the new equipment that they have, you think back when you really had to examine a patient and take a history and physical. Now you got PET scans, CAT scans, ultrasound, this, that, and everything else, which has tremendously changed the field of medicine and the diagnosis of people and everything. I think just the thing to think about is that we're going to be making progress. When you look at things here on the table, for example, how far we've come, and when we used to have to open somebody up to take their gallbladder out or appendix out or even doing a hernia repair on them, today you have it done the morning you're home that afternoon. You think of this, how far we've come, but then think, what's it going to be 10 years down the road, 20 years down the road? Going to be amazing, I think. And wish I'm not going to be around to see it. Like I say, I don't buy any long-term warranties anymore at my age. But yeah, I can't think of anything else. I'm out. Any other questions at all?
No,
It's fantastic.
it's
Been a ride. I think back and I think it's we made some good choices coming to Medina. Yep.
Good morning, Dr. Funk.
Good morning.
Thank you so much for participating in our new adventure.
Happy to do so.
So we're really talking about the history of medicine in Medina County. So when did you begin to practice in Medina?
I came down here and hung up a shingle and started a solo practice in October of 1994.
What
So
made
it's
you
been
decide?
almost 31 years.
Oh, all right. What made you decide on Medina?
Originally, I had a friend that was in medical. I was in residency at Metro, and he was in residency at University Hospitals. And he originally came down here and started talking with Gary Holman about starting up a practice, and then approached me, and we talked about doing a practice together. But then he changed his mind, ended up going down to South Carolina, and I kept the negotiations going. And so then I started the solo practice in October. The draw for Medina was I grew up in Olmsted Falls, and Medina was a lot like Olmsted Falls, especially when I was growing up as a child. It was more rural. There was a place to build. There was a small enough town that you got to know people, but big enough that not everybody knew all your business either. So it was a nice draw, and it was a comfortable thing for me. And I've been very pleased and happy that we did make the move.
Perfect. And your specialty is OBGYN.
It is.
So what major changes have you witnessed in your specialty?
Well, the biggest change that happened for us was the closing of the birthing center, which unfortunately was a real travesty to the community. I'm still looking for a good reason as to why that happened, but it certainly changed things. And now our patients have to go to either Akron or to Fairview to deliver their babies. Actually, Southwest is a little bit closer, but it's not affiliated with the Cleveland Clinic, which Medina Hospital is.
So, given that, what are your best memories and things that have saddened you over your practice?
Best memories would just be doing deliveries. It's always a special event, and doing it for almost 30 years, well, 30 years including residency. It never got tiring. It was always special. It's a miracle every time a child is born, and those are just wonderful memories. And all the happy smiles and the moms and the nurses that worked on labor and delivery. We were a community/family. It was a very enjoyable time. And the sad, again, there are occasionally some outcomes that you don't really want to have on labor and delivery. So those are sad memories. And again, just the closing of the birthing center is the biggest one.
Yeah. So given your 30 years plus of experience, what advice would you give to practicing physicians new to either Medina or to their careers?
New to Medina, I would encourage them to be involved in the community. Get on the hospital staff, but also get involved with the community. Get to know people, because it's a good community with good people. And unfortunately, I think some of the physicians today, they live in other towns and they come to Medina Hospital, and so they're not as engaged. I think they should be. It benefits them and it benefits our community as well. As far as the medical students, I think they need to use their gut, basically. Now they're using their phones and their computers, and they need to do hands-on. They need to touch people, which you find that becoming less and less. They're just ordering tests these days. And, to get to know people as well, to get to know them as a person, to think outside the box a little bit. Everything's not black and white, and people don't fit into round holes. There's square pegs out there. And you just get to know people, get to know the community, get to know your patients. That would be the biggest advice.
So in summary, are there any other general thoughts that you would like to share about the history of medicine in Medina County, your career, current advice?
It certainly changed. The medicine has changed. Medina has changed over the time that I've been here. When I came down, it was a small community hospital where we all knew each other. We had meetings together. Everybody knew each other well. And it's unfortunate we've kind of lost that. It'd be nice if it went back. Probably won't. We're now part of the Cleveland Clinic, and so there are people downtown that are making decisions here in Medina, and I'm not sure that's always to our benefit. What'll happen with medicine in the hospital? I think it's going to exist, but it's changing some already. They're getting to be more specialized in things like orthopedics, and certainly my field, unfortunately, there's less and less of that. The providers that are still in my practice, they're working part-time, so they're not working as often. So there's not the GYN presence that there was in the past. And because the birthing center is closed, the other practice in town takes all the patients up to Southwest. So there's been a real change. And unfortunately, I don't see a correction coming for that direction. And it's just part of the way medicine is these days. It's becoming more niche, and certain hospitals specialize in different things. And I think, unfortunately, that's the way we're going. And I'd like to see that community hospital back again, but I don't know that we're going to get that.
Well, thank you so much for your time and your thoughts. And thank you.
You're welcome. Good luck with the project.
Thank you.
Okay.
Good morning and welcome back. We're continuing with our physician. interviews. So could you please welcome Dr. Jaysawal? Dr. Jaysawal, could you tell us a little bit about yourself, why you decided to practice, and how you in Medina, and how you actually ended up in Medina?
I graduated from medical school in 1962 in Patna, India. And then I went to England in 66. I traveled quite a bit around different parts of the world and stayed in England for about 9 years, 3 years in Canada. And then I didn't like any one of those places. I got fed up. So I started looking around. Came to the United States in 1978. I was working with a group in Cleveland and was also senior clinical instructor at the Kase University Hospital for a year. And then I started looking for a place to practice. I was very academic minded right from the start. I worked in very large hospitals, in teaching hospital in India, and very large regional hospitals in England. So academic minded. I started looking around and I found that University of Illinois was opening a new medical school in Peoria. So I went there, interviewed, and they accepted me, offered me a position as associate professor of medicine. Then I came here and I met some friends. And my wife and my friends, they started convincing me to try private practice instead of going for academia. So one of my friends brought me to Medina and introduced me to Ed Hall. Ed Hall was the administrator of this hospital at that time. And I tell you, nobody says no to Ed Hall. He was, amazingly, he convinced me that the best thing for me is to open my practice here in Medina and go from there. And I also looked at this hospital. It was a Medina community hospital at that time. And when I looked at it, because of my background, I kept on thinking, I can do a lot of things in this place. And Ed was very cooperative. And so I joined Medina Hospital in 1979 and have been there since I retired in 2010. And when I came to Medina, how I came to Medina is totally karma. It's very difficult to explain to you fully how this happened, but it has happened. And I've not regretted it one bit since I've come to Medina. The good thing was that Ed Hall was very cooperative and allowed me to do a lot of stuff that they were not doing here. And so I talked to him about cardiology, which was, I have a broad training and experience in internal medicine with a special attention, special focus on cardiology. So I talked to him about cardiology and he was very enthusiastic about it. So he allowed me I implanted the first permanent pacemaker in Medina Hospital's history in 1980 or 81, I think 81. And I had implanted quite a few in Canada, so I did that over here. When the electrophysiologist, the specialist in electrical medicine of the heart, started coming here, I stopped doing it and gave my patients to them. I introduced echocardiogram to this hospital. We didn't have echocardiogram at that time. I also introduced a remote heart monitoring called Holter monitor of the heart to this hospital. Those are the two things that I started. Plus, they were transferring a lot of patients from here to Akron or to Cleveland. Uncomplicated heart attacks, we could treat them here, no problem. Some patients with serious pneumonia, there was no need to transfer them. We could intubate them here, treat them here, antibiotics, and follow them closely. If they needed any intervention, then we transfer them to the bigger institution. Otherwise, we started treating them all here. And that's how my practice started. The most beautiful part of my practice was done by nurses in this hospital and other doctors. They started referring patients to me, and the nurses spread the word for me, I think. And I got their patients, their family members, their friends, they all started coming to my practice. And Fortunately, it was very, I'm very proud to say that in 3 months, my practice had almost become full, which was not known at that time, especially in a small place like this. And one of the other things that I'm very proud of is that we had a retreat from Medina Hospital a few years later, and we were having lunch, and there was a speaker from IBM. I forget his last name, but his first name was George. We were having lunch at the table together with Ed Hall, George, and I think Dr. Astriaco was there too. And I suggested to them at that time that we should change the name of this hospital to Medina General instead of Medina Community, because that denotes a much bigger institution, and we wanted to make this a regional medical center. So, and they both agreed at that time, and then George and Ed Hall decided to change the name of this hospital to Medina General Hospital. And so that's how this hospital became the General Hospital. Ed Hall brought a lot of different specialties. He invited quite a few of them. And that's how the hospital grew. And really had become a regional medical center in many ways until the Cleveland Clinic and they decided to buy us. This was a great hospital to work in. The nurses were, wonderful. It was like a small family in many ways. People in the administration were very friendly. And the other colleagues, there was a sense of very, very close friendship, collegiality amongst the doctors.
So you've talked a lot about the changes that you've made at Medina. Can you talk a little bit about the changes, any of the major changes in your specialty of cardiology?
Oh, now because the Cleveland Clinic has taken over, actually even before the Cleveland Clinic, they had opened a cardiac cath lab in this hospital. I'm not an invasive cardiologist, but there were some doctors here who did invasive procedures. So they did the heart catheterization at Medina Hospital. And then when the electrophysiologists started coming, they started doing all kinds of very invasive permanent pacemaker implants in both sides of the heart. Initially, we used to put it only on the right side of the heart. Then they started doing more invasive procedures. If they needed more than that, they used to take them to the bigger institution in Cleveland. But they started doing a lot of things over here. Other specialties grew. The orthopedic department became wonderful. There are a number of doctors that came in. The rheumatologists started coming in. And of course, ophthalmology, he brought some, Dr. Mast brought some partners with him, and they expanded the hospital. They started doing a lot of cataract surgery here. So there were many, many advances that occurred. Plus, the hospital built this new wing, and the new wing was a wonderful addition to the old hospital. And they got a number of new nurses, who were trained with higher training. There was a tremendous amount of advancement since I joined the hospital.
So I know that you have many memories of your practice. Would you like to share maybe what your most poignant memory is of your practice in Medina?
Initially when I came here, as I told you, I was very academic minded. I was not sure I would really get satisfaction personally. Fortunately, because of the background of internal medicine, I also saw a lot of internal medicine patients. We had I was amazed at the number of rare conditions that were still around in this area. And what impressed me most initially was the number of underactive thyroid that was in a number of places, especially in the Lodi area. Patients from Lodi area, I was amazed at how many underactive thyroid was there. Then we had some very rare patients. One of them was a lady who had seen a number of doctors with no diagnosis. She finally came. I examined her, and she had a changing heart murmur with posture. So that made me start thinking there's either a tumor there or there's a ball valve thrombus. So I got an urgent echocardiogram done. She turned out to have a left atrial myxoma, which is a tumor most cardiologists will die and not see one. And I saw one in Medina. You know. So there were a number of other conditions. There was a neurological patient who was having a lot of problems with muscles and things, and people didn't understand what was going wrong with her. So I examined her and told her, okay, I think I know what you've got. I took her to my restroom, put the water very cold, told her to grab hold of the faucet and let go, and she could not let go at all. So finally I turned it and made it warm. She had a condition called dystrophia myotonica. It's a very rare genetic condition. So I told her to get her brother, her family members checked out. Her brother also had the same thing. This condition causes a heart block. So when I examined her and I did the EKG, there was a first-degree heart block. And I told her that initially it is only mild, it'll continue to progress, and it will need a permanent pacemaker implanted. And eventually she did. The heart block became more and more, and she had a permanent pacemaker implanted on her. So that was the two very rare conditions that I saw in Medina.
That is amazing. Thank you for sharing. So, what do you think is we're going to change it just a little bit. So, what do you think is the best change that you've seen in medicine in general today?
In every single week, there's a new advancement. In cardiology especially, plus the drugs that we are using now. When I became a doctor, I was asked to give a lecture to the dentist one time. And the first question they asked me, what do you do today that you learned in the medical school? I told them, nothing except the basic pathology that we were taught. That has built up the background of medicine. There's so many new drugs that came out, so many new procedures that came out, and so many things that we could do that we hadn't in 1962 was not even thought of. And now you can see, especially in cardiology, there's so much advance in cardiology. They can almost go in a pregnant woman and a child with a heart hole. They can go in a pregnant woman and close that hole in the heart, while she is still in the womb. So there is huge amount of practice improvement that has happened. Thank God for that. That's why people are living longer now. And before when I became a doctor, there was only 2 drugs for high blood pressure, and there was hardly any drug for diabetes. Now we have hundreds of them. So there was a tremendous advancement that has occurred over the years. Plus, I'm sure that there are surgical procedures, orthopedic procedures that they are doing now that were not even heard of before.
So, with all of the changes that have happened, is there anything about them that saddens you?
Exciting?
Saddens. Makes you upset, or that you miss, or
the only thing we old doctors miss is that we don't see the same kind of camaraderie amongst physicians. Number 2, the corporations have taken over. They have turned it into a business. When I went to medical school, I did not have a single class, not even one class on how to run an office. There was no business news. Nobody knew that. We just went into practice and developed it. Now I'm sure that they are taught. The thing that bothers me the most is that when you go to a doctor now, they've got a 15-minute slot. We in practice saw the patient until they were satisfied. It was very different. They were like a member of my family. I could not let them go without satisfying them, and telling them exactly what they wanted to hear or what they wanted to know. That is something that personally, as a patient also, I've felt it when I go to see a doctor. They look at the time slots and you're out.
So, given your extensive experience, what would be your best advice that you could give to new physicians in their practice, or new people coming and thinking about becoming a physician?
Be very compassionate with the patient. That would be my first advice to any not even doctors, but everybody, but the doctors especially. People are sick, they need help, and you have to be really compassionate with them. Take care of them, talk to them. Unless what happens nowadays, they've got this laptop and they're typing this and they're asking questions, and we never did that. Face to face, listen to the patient. As a matter of fact, 80% of my diagnosis was made by listening to the patient. 20% and 10% was by examination and 10% by tests. 80% of the diagnosis I made was just listening to the patient.
So what do you think you see? What do you think you see in the future for both the cardiology profession or specialty and medicine in general?
I'm afraid it will be machines. The machines will be taking over. You will come in, even now, before they see you, they do an EKG on you, in cardiology. Number of patients, if they have a murmur, they tell you, go and get an echocardiogram done before the doctor sees you. The advancement in machines, the AI, artificial intelligence, that's going to happen, will be making there are two parts to it. One is the good part. The diagnosis will be so easy to make with the AI and all those things. They have diagnosed conditions that was difficult to diagnose or not diagnosed. The bad part is that the rapport between patient and doctor is going to be missing, unfortunately.
So, in summary, do you have other thoughts that you would just like to share in terms of the practice of medicine, either in general or in Medina?
Well, Medina has improved tremendously since I first came here in 1979. It was a community hospital. Then it became the general hospital. And now it's a part of the Cleveland Clinic, the huge, big conglomerate. There has been advancement because they have brought a lot of specialties and machines and surgeries and all kinds of things. Most of the advancement that I think will happen will be related to the AI, as I'm seeing it right now. They are going to make drugs, do investigations, testing, make it so much easier. Over the years, it will become, that is the thing that's going to happen next to medicine, is the AI, artificial intelligence, as I see it. I may be wrong, but that's my reading right now, that this is going to happen. And the doctors will just be carrying machines in their pocket, and they will listen to you, and that machine will really give you the exact diagnosis, and maybe even treatment plans. The drugs, they are going to explode. Right now, there are already new drugs that are coming out that are just totally amazing. The future of the drug industry that I see with AI, I think is going to explode. It's going to become so much easier. Unfortunately, it'll cost a little bit more. But cost aside, I think it's just going to be a tremendous advancement in taking care of patients and people.
Thank you so much.
Great. Good job.
We very much appreciate your expertise. And
Thank you.
When did you begin your practice here in Medina, and why did you choose this area?
We got here in 1978. I had been in the Army at Fort Sill, having gone through advanced ROTC at the University of Akron, and knew I had 2 years to give, but received deferments for medical school and residency. So medical school at Ohio State, and then residency in Roanoke, Virginia. I was the only resident north of the Mason-Dixon line in Virginia during that time. And then at Fort Sill, kind of met back up with Mark Spielman, because he had taken a different path after Ohio State and gone to California, and then ended up in Oklahoma at Fort Sill. So we got together and decided that we would go into practice together, since he was from down toward Mansfield. And I looked around to places to practice. Always wanted to come back to Ohio, near family and friends, since we're from Cuyahoga Falls and Akron. And looked around and decided on 3 different places to look at: Mount Vernon, Dover, New Philadelphia, and Medina. And it was a hard decision, but the right decision. Thoroughly enjoyed it in Medina. Chose Medina because of Medina Community Hospital, and a place where I could practice the whole scope of medicine. So doing OB and newborns and pediatrics, where I could assist at surgery, admit to the hospital, to do everything which I had been trained for. And I was fortunate enough to meet Bob Smith, who was a physician here in the 50s, 60s. He was just leaving town, and he graciously said, "You could take over my office space, you can have my records." So I had a built-in practice when I started. And Robertson and Miller, doctors here at that time, said they would cover for me and I would cover for them. So it was really a perfect setup to practice in Medina. And we loved the community. It was only 20, 30 miles away from home, my parents and family. So that's why I chose Medina.
Good, good. It's interesting, the changes you must have seen at Medina Hospital, going from Medina Community to Medina General, and obviously now to the Cleveland Clinic. What was your first impressions of the hospital?
The hospital was small, but that's the way I wanted it. Didn't want a giant hospital. It was not exactly bare bones, but the ICU was pretty small, and the emergency room was sort of in a basement, and couldn't do a lot of testing. Had to send some tests out, like blood gases. You would do them in the ICU, and you would have to have them couriered to Akron to get the test done. But sure was a friendly place. Ed Hall was the administrator at that time, and he was really good and great at recruiting physicians. So, and it was interesting, the changes throughout the time I've been here to the hospital, with all the additions and the takeover by, shouldn't use that word, the takeover by Cleveland Clinic.
Mm-hmm. What do you think, or what did you witness in your own family practice specialties that you think was most significant changes over your tenure as a physician?
The record keeping seems to be one of the bigger changes. We would dictate our notes and have them typed out. So it was different than having the small cards that physicians kept their notes on and put them in paper files. And then, of course, came electronic records later on. And that was good and bad for me, not growing up with computers or being able to type. And so that definitely was one of the bigger changes, the computerized medical records.
Mm-hmm.
I think when they first started, they weren't ready for prime time. And even now, they need to make changes to make it more friendly to the physicians, I think.
Is there a specific case or memorable incident that you encountered in your practice that really sticks in your head?
A memorable case. Probably not at liberty to talk about the most memorable case.
We understand. That was some of the surprise answers were quite.
You'd have to edit that out.
Right. We understand. That's okay. We'll go on. What changes, though, in medicine would you say saddens you the most currently?
It seems like it's much less personal. You've probably heard that from other people. When I was doing the full scope of medicine, including deliveries of babies, now family physicians, the vast minority don't do that and don't practice in the hospital anymore. The hospitalists take over. But at Medina, I was able to do everything I wanted, and the staff at Medina Hospital was really good. The obstetricians would help you out, the surgeons would help you out, so there was a lot of cooperation at the hospital. Mm-hmm. So now I think the family physicians, partly because of the computer, don't have the personal touch with the patients. There's a lot more technology, which is good and bad. You're able to do a whole lot more testing. And now it seems like physicians rely much more on testing than they do on touching the patient, doing the physical exam. And so that is disappointing to a lot of patients and to me.
So if you were to give advice to an aspiring physician, someone who's considering pursuing that occupation, what would be some advice you would give to them?
So touch the patient, look them in the eye, have personal conversations with them, and speak so they can understand it. Just take more time with them.
Mm-hmm. Interesting. What do you see in the future of medicine? I mean, we all hear about the wonder drugs, the AI. How would you see the family practice or physician's role changing in the future?
I guess each generation talks about the good old days. And I don't see it changing the way I would like to see it. You touched on AI. I'm still not sure what that is. Doesn't seem that it would improve the personal touches of medicine. Computer is going to always be with us, I guess. So the future of medicine, I'm not sure that it's going to be better. There's sure going to be reliance more on the physician extenders, like physician's assistants, nurse practitioners, and that's not bad. We had some really good quality nurse practitioners, physician's assistants. So I don't know. It's hard for me to predict those things.
Yeah, it's going to be interesting, I think. I don't know if you mentioned what motivated you to pursue an occupation in medicine.
Sounds corny, but when I was little, I got a medical kit for Christmas. And so at age 6, I practiced being a doctor.
The dog or kitty cat?
Yeah. And so it was just in my mind from grade school on, and it didn't change since I was successful in school. And I had some good mentors, I think. In childhood, we had a doctor in Cuyahoga Falls named Emmett Monroe, and he was, I think, the prototype family physician doing house calls in the 50s and early 60s, and a lot of awards in Ohio for being Physician of the Year. So he was instrumental as a good example. And later on, in medical school, we did a rotation called the Romance of Medicine. So for a month, I spent time with a physician in Logan, Ohio, pretty small town back then, and saw exactly what they did in a small town. And another time with a Dr. Johnson in Johnstown, Ohio. So they reinforced my idea of being a family physician.
Interesting. We understand in the history of the county, many doctors, whether they had the official license or studied under another physician back in the 1820s, 1850s, it was not uncommon for doctors to learn that way. And good or bad, some assume the title without necessarily all the depth training. But,
right. Sort of like an apprenticeship rather than
kind of, yes.
educational.
Yeah, we have lots of, our census records show an enormous number of doctors listed in the county up until 1950 and from 1850 to 1950. And we're just curious how all that would have transpired. But I think to your point, they may have studied under other physicians, kind of did maybe some minor things until they built their experience up. But they were, that's all we had. And it's interesting. From a historical society's viewpoint, we were just keen on talking to physicians and learning about your experiences, because I think they would have paralleled back 100 years ago. You would have found people learning in similar ways with maybe less technology, but that spirit of caring seemed to have carried through.
And you brought up Dr. Mansell earlier, and he was another one of the prototype family physicians in Medina.
Mm-hmm. We have his prescription pad right on the table next to you, and from what we've heard, he was an amazing physician, very compassionate, loaded with stories of his experience, and some doctors have shared some of those funnier stories they can repeat, and it was very interesting. Well, do you have other comments you'd like to share with us about the history of medicine and what, is there any other topics you wish to cover?
When I was looking for a place to practice, Medina as a community was very welcoming. So the physicians that were here, sort of recruiting me, took us out to dinner and showed us around town. And, Medina sort of sells itself in a lot of ways. Ed Hall was very welcoming, and Doctors Miller, Robertson, Dr. Mast was there to take us out to dinner. I think it was at the Oaks. So that was
nice place. Yeah, very nice place.
And they shared with us, realtors we could talk to and other people in town that we could get to know. So it was a very welcoming place. Gazette was good to put articles in the paper about us.
Mm-hmm. It seems to be a common theme we've heard, and sometimes being born and raised here, you kind of take it for granted. Mm-hmm. But from an outsider's viewpoint, coming into the community as yourself, that's kind of neat reinforcement of our culture and our community. And that's one thing on our history and our society tries to educate and emphasize is the cultural things, the spirit of things is what makes a community so good. And we're really happy that when people visit our museums, they actually learn something about people who came before them. And likewise, we'll accumulate items today that somebody will be showing somebody in 50 years from now. So,
and growing up in the 50s, 60s, even 70s in college, Medina seemed like it was way far away and out in the sticks. I'd never been here until I started looking for a place to practice.
Interesting. Well, the county has certainly grown since those times. We're over 180,000, 186,000 people now in our county, which is amazing. The number of physicians now required to serve that population, and still interact enough with the patients on a level that you'd like to see. So.
And the Cleveland Clinic has improved the hospital physically and technology-wise. The physician community, when I was practicing, was really pretty tight-knit, and we did things together. We had softball teams, we had racquetball league first thing in the morning. I remember also the doctor-lawyer golf outing. We were on good terms with the lawyers. So it was a fun place to work. Now I don't think a lot of the people who practice at the hospital live in the community. They come from elsewhere, put their time in the hospital, and then go back to their home. So not as many live in the community, which is not good in my opinion.
Okay.
Because it was neat to be in the community, run into people at the different stores and events in town, to really get to know people that way.
Well, people recognize you and your fellow physicians in times of emergency. It's awful good to know who's available, who's right in the room or church or school or whatever might be the case. Football games, if there's an incident, I'm sure you're looked upon quickly as someone to summon and help. And I think that's a tremendous community service physicians often supply. I'm sure you come to events for other reasons, but sometimes when you're called upon, it's a great relief to people.
Yeah, it's happened, a lot of times in the past. I'm, at church a few times, people would have a problem, and the doctors who lived in the community, and there were a lot of people attending same church, St. Francis, and they would be able to help out people who had a problem.
I'm one of those ushers. That first thing I scan the crowd when I'm ushering is, okay, there's Tulsiak, there's Naples, there's Kase.
That's right.
I kind of do a quick scan of the audience to see just in case. And I have been one of those guys that has called upon our doctors in times when, we train on AEDs now and basic first aid, but there's nothing to replace a physician's competence being right there and so forth. Well, great. It's been great interviewing you. Dr. Jeff Kase will be compiling these stories among others, and we thank you for your time and your insights, and I think it's going to turn out great.
Thank you. It made me think a lot of some old memories.
Yeah, that's what historical societies like to do.
Yeah, that's right. That's right.
But it's been really interesting, and your comments do mirror many that we heard, and the community feeling in that hospital and being so close. When the medical buildings were built, finally being able to have your practice and be a short hop from the ER or where needed. And
if the surgeon had to get over to the hospital, or if you were delivering a baby, just to walk across the parking lot. But most of the time, they had babies at night, in the middle of the night.
I don't know if you ever knew Dr. Avery or Wolf in Seville.
Sure.
Avery was supposed to deliver my baby brother, and he had just had the driveway put in at his house in Seville, long serpentine driveway. And my dad joked with my mom that, God, I hope he doesn't drop off that driveway with that big old Cadillac he was driving. And that's exactly what happened the night my brother was born. I'm not sure how he ever did get to the hospital. I guess the car probably got stuck being off the driveway, but
not horse and buggy at that time.
No, it wasn't horse and buggy, but I think probably upset my mother a little bit. Yeah, I'm sure neighbors must have got him there in time. But.
Yeah, Avery and Wolf, and Dr. Austin was another doctor who was a real gentleman and a good obstetrician in town.
We used to joke about Wolf and Avery. That was our family physicians, and we'd go to the Seville office. They had the same block of wood holding up the edge of the sofa
our whole life. I said, they didn't invest a lot in office furniture.
Right.
They were very not simple doctors, but they didn't seem to matter on those kinds of things.
Yeah.
So
that wasn't the important thing.
that's exactly right. And they were, of course, they made house calls back then. That's kind of a bygone era. But I think what we intend to do is, between our timeline, our audio, and our other excerpts, we'll assemble a very nice exhibit, and I hope it turns out good.
Yeah.
And I think all of your
one of the worst things
have been
that the hospital has had, and this probably has been mentioned, was the loss of OB.
Yeah.
So that was sad for the community.
Jonathan Funk was really big on that one, of
Yeah.
course, and so was
Tulsiak.
Yeah, and even Denny Robertson. He said, it is sad. You have to go so far to have a baby,
right?
In this day and age, and well, I'm sure there are a lot of different reasons for that decision. It's still, we don't have my nieces and nephews are now having children, and I'm often wondering how they're managing all that, whether through midwives or they live in different spots. They know where to go to get help.
I wasn't in on the decision making at that time, but it seems like it was a financial decision. OB didn't make the money for the hospital, and the stated reason was that smaller hospitals, if you didn't do a certain amount of deliveries, then there were more complications. But that really didn't apply to Medina, because we didn't have the complications as much as they were talking about. So yeah, that was a big loss.
Yeah, maybe someday somebody will rethink that. Who knows? But not in the cards, I don't think, right now. But
yeah, I can't predict that in the future.
Well, anyway, I think that pretty well wraps it up.
Okay.
And
hello, I'm Dr. Keshock from Anesthesia at Medina, and I understand this is going to a really wide audience, but I'm eager to share some stories from medicine and maybe from a woman leader perspective, because it's always important. We have students come through for anesthesia, but also just sharing stories, I think, is one of the best ways to learn. We're all visual learners now, so we're going to put the name to a face.
So welcome, Dr. Keshock. So you're currently practicing in Medina. How long have you been at Medina Hospital, and sort of how did you get here?
Well, I joined the Cleveland Clinic system after being in private practice for a while, just because they have such good quality metrics and quality scores. So that drew me to the clinic after private practice. And then I was the director at several other sites, Fairview, Lutheran, and Fairview ASC, but I enjoyed being at Medina as my favorite, and then became the Southern Sector chief down here and just couldn't leave. So now I'm in the medical staff leadership at Medina, and will be president of the medical staff next year.
Congratulations.
Yeah, thank you.
So we've talked a little ahead prior to us recording about the changes that you've seen in anesthesia. Could you just kind of take us from, back in the 70s or earlier to what currently, what's the current practice in anesthesia?
Well, we're always the patient's advocate, just like the surgeon is, and the whole team, nursing, obviously. But we're there to control pain and make it I kind of say I'm your anesthesia ambassador when you come to Medina. But I also have students come through, and I find myself frequently saying that, we used to do it this way, but now there's new techniques. So even going back 20, 30 years, we're using better medicines, more multimodal anesthesia, so during pain blocks, so people don't get as much narcotic. And we got away from some practices where we're just doing blind techniques. We use ultrasound for everything today, so that's just a great modality that's come, and everyone's using it for everything. We still are very hands-on, but anesthesia is basically making the patient comfortable and ready for surgery, and sometimes canceling the case if they're not ready for surgery, but it's incredible changes. When I was doing my residency, people had still experienced ether anesthesia. I know my colleague here is also had ether anesthesia. Some people have had their tonsils taken out in the kitchen table, and these things are all just within our memory banks. My mom was a family practitioner, and she grew up on a farm, so there's all those farm stories. And basically the bottom line is there was not enough anesthesia providers to go around. So whatever farm accident happened, they, had to do a lot of stuff without anesthesia. So anesthesia makes a lot of things possible, including something as simple as childbirth with epidurals. We love to be the patient's new best friend when we give them an epidural. I've heard that a lot, but I love that. And that just makes it a really good day. But we aren't doing OB at Medina anymore. We're doing a lot of orthopedic surgery, which is fantastic. Nobody has to be scared to come and do their knee or hip because we'll make it a good experience. A lot of general surgery with Dr. Dawson, and a lot of GI. Dr. Merheb is also a leader at Medina for GI.
So, we're interested in the history of medicine in general. So, in your specialty and in your growing up in medicine, what major changes have you seen just in medicine in general?
I think imaging is really incredible. Not to take anything away from the people we stand on their shoulders that were so good at physical diagnosis, but I teach some of the case medical students physical diagnosis, and there's incredible physical science that you have to learn and be able to teach. And we're getting some background music. It's all good.
I'm just going to shut my phone off. I'm sorry.
That's good. And
Delivering epidurals.
So we are, doing a history of medicine in this exhibit. And so we're curious about what major changes you've seen or read or heard about in medicine in general over the years.
Well, when the Human Genome Project was completed, it's almost scary how long ago it was that now, between 10 to 20 years ago, that enabled more personalization that's yet to come out. Because we see kind of a 10-year time lag before anything really gets out into the periphery. That's a major change. And whether it's going to be directed cancer chemotherapy or even antibiotics or even, brain health, there's still more changes just to come. And also public awareness about what's important. Would you believe we're still telling people not to drink? I mean, and that's just something that we should have been saying for the past 50 years. There's other dramatic improvements I mentioned with imaging, surgical techniques, the whole laparoscopic environment of minimally invasive surgery is night and day, really, what patients had to endure and how we used to immobilize patients afterwards. And now we're just kind of going a 180 and saying that you do your best when you start moving afterwards. And then from anesthesia, we'll make it possible. We'll make you comfortable. So those are, I think, the three major changes.
Perfect, yes. So in your specialty, is there a poignant memory that you have either with the surgical team or with the patient that you would like to tell us about?
I think I'm going to share this story with you because it is about a case that I canceled. So we didn't do the anesthesia. But the reason I bring this up is because it was more in a male-driven environment where the thoracic surgeon wanted to do a very aggressive surgery on a lady who had cancer, and she just wasn't able to stick up for herself. And her daughter really thought she was torn. Should she do this major surgery for her mom's esophageal cancer? The surgeon said, you know, you're going to die in your own secretions if you don't get this done. And the patient really was torn whether she should do it. And so I feel like that's probably my special skill, that I can listen, because there we are ready to go back. And she was just like, I don't know that I need to do this. And I said, well, no, we'll make you comfortable. It's the whole hospice aspect, which is also a relatively new change. And just kind of bringing the patient, the surgeon, the daughter together. So we didn't proceed on that. And I'll just never forget that case, because we made her comfortable, and she was able to communicate until she wasn't, versus being on a ventilator. So I remember that case, because, you know, if it's not that you're standing up to the surgeon or anything, but just approaching it as a team and, you know, colleagues, say, hey, giving everyone a minute to think, I think.
Perfect. That's a great story. Yes. So we've talked a lot about the positive changes in medicine. Are there any things that you see coming that would sadden you about the changes in medicine?
That's an interesting question, Fran. Something maybe we should put it on our watch list. Like, oh, let's be careful. So I'm obviously not the first to say this, because we've got national leaders that are saying we should pause on AI. And I'd have to say I agree with that. If they ever got rid of our radiology colleagues, or there's literally sources, I don't know how to call them references or not, that say that general surgery will be overtaken by robots. That's not going to happen, because judgment is not something you can just put in a bucket. It's a very important part of the team, and you can't have a robot do all the surgery. They're just an adjunct. So I don't know. It's almost like I gave you that question to ask me, friend. That's a brilliant question. So I just wouldn't put all the eggs in one basket for AI. It can help us, but then just the listening is so important. At this age, I've been a patient myself, and you can really tell who's listening to you and putting everything together. So some of my favorite doctors are podiatrists, because they will listen to you. And they're not just paying attention to the toes. So yeah, Matt Testrake does a great job at Medina. But I would say a lot of the surgeons there are very excellent. And we're just lucky to have a really good crew.
Yeah, for sure. So you told us earlier that you have a daughter who's coming into medicine as well. So what would your advice be to new people who are thinking about going into medicine, or just starting their journey in medicine?
Well, I think I'm lucky enough to teach some of the Case students, and they're all so smart that they almost don't need my advice, but we do, you know, share pearls here and there. And I think what they like to hear is that you can do this, but, you know, you're going to be a lifelong learner, and you really do have to listen to your patients. And sometimes, you know, nobody's at the top of their field when they start. So sometimes you're going to be the younger person in the room, but you may know the patient the best. So you have to advocate for them, no matter what your station is or your accomplishments to this point. So that's one piece of advice I would give. And then I'd also say, don't worry about AI, because word spreads like crazy when you have a good doctor, when you are a good doctor. And so you don't have to worry about job security if you're a good doctor. I guess that's a good way to put that.
I would agree. Absolutely not.
Yeah.
So I know that you've been at Medina about 6 years. So what do you see as the future of Medina Hospital or medicine in Medina County?
Oh, I'm so curious as to how my colleagues answer that. But Medina County is growing, and the hub here for medicine, I really think, has a strong reputation. So we are a bit landlocked. I won't talk about the parking problem, but it's a great place to have surgery. I think the future will be orthocentric and general surgery because people need that, and it's very much a satisfier to come here and get excellent care. Other service lines are also very strong. The future of Medina would be that we're part of an incredibly, the #1 employer in Ohio with the Cleveland Clinic, and that reputation is well deserved because of our resources. I can pick up the phone if I have a question or my colleagues have a question and ask anybody at main campus. It's nothing that's not important. So I think our future is secure and we can serve the county very well and incorporate hopefully a little bit into the west and further south.
That all would be very great.
Yeah.
Thank you. So, kind of in summary, are there any other thoughts you would like to share in terms of either the future in anesthesiology or in medicine in general, or just anything that you would like to just share with us?
Well, I would say that just from a woman in medicine perspective, and your timing is excellent. I think next Tuesday is National Women Physician Day. So I don't know when this exhibit will go out, but I would share that it's part of just really helping people with their lives. It's a privilege to get to be someone's doctor and caretaker for the brief time, or even mini surgeries that we get to see somebody. And that type of person is going to be a curious and advocate for their patients, and then with engagement, you just kind of naturally fall into leadership and making sure that things are done well from an operational efficiency too. So
I guess I do have like one follow-up question, because you've mentioned you're in the leadership role. Have you found that to be challenging, or is it satisfying, or what about leadership drew you to it?
Well, actually the quality part of it.
Okay.
You know, I started with being a quality officer, quality metrics. It's something that you not only check a box, but yes, we can do this. We can decrease this infection rate. I think leadership has taught me to be a very active listener. And sometimes you're looking at a dysfunctional team and you're working with a dysfunctional team at the table, but you know you're still going to work together. Take a step back and realize we can accomplish something greater if we just let everyone say their piece. So try and be a servant leader. So, you know, I'm not only there filling out a computer survey or trying to get the floors mopped, but also working hard and making sure the schedules are good, and then serving the medical staff too at Medina. So
perfect. Yes. Any other thoughts?
No. Can't wait to see the exhibit, I think.
Yes, we so appreciate your input and being a part of this. So thank you so much, Dr. Keshock.
Yeah.
Thank you. Very good. Yeah, very.
Hello. Would you like to introduce yourself?
Sure. My name is Lynn Mast. Lynn with an I, Linn, Mast. And I've been practicing here in Medina since 1977.
What are some of your first memories of practice in Medina County?
When I first came to Medina, there was one ophthalmologist who practiced here just a couple days a week. He actually lived in a suburb of Cleveland and used to drive down here for 2 days. And he had an interesting scheduling system. He had 2 appointment times. One of them was at 7:30 in the morning and the other one was at 1 o'clock in the afternoon. And if you got an appointment, called his office and made an appointment, you got an appointment for one of those 2 times. Then all the people who had an appointment at 7:30 showed up, and whoever got there first was the first one to be seen. So you could have an appointment at 7:30 and not be seen until 12:30. So we started off with giving individual appointments at specific times throughout the day. And from the time we opened our office in 1977, we were busy from the first day, which was kind of obvious for that reason.
Oh, wow. What changes at the hospital made the most impression on you?
When I first came in 77, the emergency room was down in the basement of the hospital, and it was less than ideal. It was a definite basement, and as far as ophthalmology was concerned, they didn't have any slit lamp, magnifying glasses, anything at all like that. And I got called in for almost every eye case that came to the emergency room because I was the only one that was here full time. And we didn't have a whole lot of equipment there, so we managed to work on trying to get that. The changes that they did, they bought a slit lamp, bought other equipment so that we could finally examine people.
What major changes did you witness in your specialty?
There were a lot of changes. Actually, in ophthalmology, there have been some significant changes over the years. We're talking from the 1800s up through the present time now, and actually the ophthalmoscope wasn't even invented until about 1850. So doctors who practiced oculism rather than ophthalmology at the time couldn't even examine the eye. They just had to look at the outside. So there's some huge changes over the course of time. The development of cataract surgery, from the first cataract procedures that they did was called couching, where they actually took a needle and just stuck it in the eye and pushed the lens out of the way so that you could see through that thing. They didn't really remove the cataract. Again, with no antibiotics or anything, there was an awful lot of infection, and so the success rate was very, very slow. Over the course of time, we invented the ophthalmoscope, and we developed cataract surgery where we could actually go in and remove the cataractus lens. Then we've had all kinds of changes over the years with instrumentation, the development of first intracapsular, that was taking the entire lens out, then called extracapsular cataract extraction. And then we had phacoemulsification, which came in about the 1960s or so, where we went in and broke up the lens and took it out. We could start to use smaller incisions instead of the great big incision to remove the lens. Intraocular lenses were started in about the 1940s, didn't become really popular until later in the 60s or so. Then with the phacoemulsification, where we broke up the lens, we could put make a small incision and put the lenses through that. And the changes in time spent after cataract surgery was phenomenal. When you first had a cataract operation, you used to stay in the hospital for a week. Even when I came to town, it was 3 days you stayed in the hospital. First, it was sandbags around your head so you couldn't move, and then not when I was there, but before that time. Now, people come in, have the cataract surgery, and walk out and go home. Such a change in things. Changes in retina, changes in strabismus or crossed eyes in kids, changes in macular degeneration. With the new AI things that we're doing and genomes and all sorts of changes and things, that progression in ophthalmology. So,
Wow. What do you think is the best change that you see in medicine today?
With all the progressions that we've had with antibiotics and insulin and all sorts of things, but the best recent change probably, and this is strange, is the development of the electronic medical record, which allows us to access all the information about a patient, no matter where they are. You can be traveling all across the country, all around the world, and still have available all the background information on every patient, which makes it much easier rather than starting to see a patient de novo with no information whatsoever. There's some drawbacks to that, but as long as it's used properly, it's probably one of the best things that I think we can find. Of course, the development of AI and genomes and all sorts of things also add to that.
On the other side, what is the change in medicine today that saddens you the most?
I think probably the biggest change is the shift from the practice of medicine by physicians. It's becoming a big business now, the business of medicine. We've lost, I think, the personal touch for medicine. Individual, looking face to face with with people and taking care of them personally, knowing them on an individual basis. That's sort of been lost, I think, now that doctors are employed by all sorts of large companies and have to meet timelines, seeing only 15 minutes to spend with a patient. I think that's been a sad thing. But again, it can be utilized if the doctors realize that they need to develop that relationship.
What would be the best advice that you could give the physicians practicing today?
Know your patient. I think, again, the tendency with electronic medical records and the way we're moving now is to see a disease process rather than a person with that particular disease. And I probably would say, learn to know your patient, look them in the face, know who's sitting in your exam chair, and don't just think of them as a problem to be solved, but a person who has a problem that you want to help through their difficult times.
Hi, my name's McKelvey. I am a board certified OBGYN. I have been practicing here in Medina for 25 and a half years. I'm potentially an oddity in medicine. The first job I started, I'm basically at, and that's not super common. I joined the practice professional OBGYN in the summer of 2000. I did my training in Akron. My husband's from the area, so that was an important thing to stay local and near family. And it was a great fit. And over time, as our community grew, but the issues with medicine became more challenging. And when Medina Hospital became affiliated with Cleveland Clinic a couple years later, our practice was then bought out by Cleveland Clinic. And I have been a Cleveland Clinic employee for almost the last 15. It'll be 15 years in a couple weeks and a couple months. So.
Wow. Yes. Wow. So, so you've sort of given us the background and why you decided to practice at Medina, which is very fortunate for Medina. So we're really talking about the history of Medina and Medina Hospital, and in medicine and in healthcare. So one of the things that we're interested in is your understanding or your version of the changes that have happened at Medina Hospital and what's been most impressive to you.
Okay. So one of the things that I looked at coming out here to Medina, I really was drawn by the amazing care that was being provided by a small community hospital. And the group that I joined, my two partners, I think we were giving that best world-class care, our Cleveland Clinic tagline, well before the Cleveland Clinic was a part of our venue. And I think all of the providers at Medina were doing the exact same thing. So I think that's one of the things that really impressed me, is that the level of care that we were seeing at this small level 1 community hospital rivaled, I think, a lot of our local bigger institutions. Unfortunately, and I think everyone's aware of how things change over time, the ability to be a small community hospital and support that for the community and be able to continue to give that care without larger support, I think became challenging over time. And so then in the late 2000s, the Cleveland Clinic was able to come in and support Medina Hospital, and so now we are affiliated. And I think that's one of the other impressive things that we have is that we're able to continue to give that small community feel for the care and that world-class care with the big support of when there's something we might not be able to offer, we have easy access to those tertiary facilities. They're right, we're in their backyard and they're available for us for help.
So we've talked a little bit about the changes in the hospital. What changes have you experienced in your specialty?
So probably the biggest one is that over time there is a move more to centralization of care. And so not every facility will continue to do all of the things of medicine. The perfect example is that our birthing unit, which is where I was able to deliver my 4 children, and I delivered hundreds of babies myself, was closed in the summer of 2017, with the look that having all of our patients being delivered at a tertiary facility. And while I do miss that small hometown feel, I think we still get a little bit of that at our bigger institutions, but we're able to give basically everything, instant access to all the things that any of our moms and any of our babes might need. Whereas in the past, if we had a mom come in at, say 34 weeks, preterm labor, that's not something we were able to care for, and they would have to get shipped. They would be shipped out anyways. So this 2010, we were going to ship a 34-weeker out. Now everybody's going, but we still are able to be involved because when our unit was shuttered, we became affiliated with the call group in Akron. So we're continuing to be able to provide that inpatient obstetrical care and still get access to delivering babies, which is one of the great things of my job.
So as you think about your practice over the last 25 years, which I'm amazed at, what are some of the poignant memories that you have of your practice at Medina?
I think very early on, when I started, one of my biggest things that I can remember is I was just out the first couple of months, and my partner routinely would take like a 2-week vacation. He had a patient who needed surgery, and he's like, "We're going to hook you up. We're going to get you started." Well, here's the thing. That's what you do. You spend 4 years training to come out and put your big girl pants on and do things by yourself. And so it's nice to have the support of, let me help you out. Let me get this going. And realizing I've got everything I need here, and I can do this, and I can take care of this patient. And my partner trusts me, and this patient trusts me with, their care. That's really one of the biggest things is, the honor to be able to care for all of the patients. There's so many amazing memories that I have. I don't think I can really pick out one specific.
So one of the changes that we've talked about with some of the other interviewees is really the number of women who are in medicine today versus, maybe even 25 years ago. So what changes do you think that has brought to medicine today?
My hope would be that really not a lot of changes, because we should all be able to give that empathetic, compassionate care. I feel in my specialty, we have a little bit of an extra advantage because a lot of the issues and experiences that we're discussing with our patients, we've had personal experience with. I routinely will hear from my partners, I've never had a heart attack, but I know how to care for someone who comes in with chest pain and is having a heart attack. And I get that, but I think there's a little bit of a different bend, especially caring for women, that having that personal experience and going through a pregnancy and a labor, starting to deal with the issues of menopause, that we just have that extra connection, at least in my specialty. But across the board, I think the ability to figure out how to make all of the puzzle pieces fit. Not all, but many women in medicine are moms. And my standard is when I walk into a room, a patient says, "Oh, I'm sorry." Listen, I'm a mom. I'm going to work with whatever you give me, and we're going to make it work. And we're going to figure it out because you need to.
What advice would you give to someone who's entering medicine today?
Start off with figuring how to make all of your priorities work together. It is a big challenge to juggle that life-work balance. I'm probably not the best person to ask about that, especially if you've discussed it with my family. Although I believe they're likely none the worse for wear. They still talk to me when I get home from work. But knowing when to step back from your work and be able to bring family up a little bit more, but also those times when work will become more of a priority, and already having those conversations established with family so that there's that understanding of you guys are neck and neck for number one. Sometimes work needs to take a little bit, but then there's going to be times when you get to take that lead too.
So what would you see as the future of medicine, and maybe in general and then in your specialty?
I'll start first with my specialty. I think there's some of a push to look more to that division of labor where we see patients or providers who work primarily just in the outpatient world, and then the hospitalists or laborist groups who really are then taking care of patients or once they're in the hospital, which is very, very, very different from when I started 25 years ago, where you're the one person who does everything all the time, in the office all the time, on call, in the hospital, in the ER, in the OR, on the OB suites. And I suspect in general with medicine, I think there's kind of more of a push for that, where that's giving that ability to have a better work-life balance. And with that, then the ability to continue to practice as long as possible. Obviously, seeing all the shortages that we have in nursing and medicine, that we need people who are going to be here for the long haul, and seeing maybe that shift, that paradigm shift in how we provide care. I think part of the goal is to support that.
We've talked a little bit about it with others about AI in the future of medicine. Do you have a sort of a sense of what that will look like?
I mean, we're using it now, really more as right now, I can speak to my personal experience with AI. We use, the clinic has a generative AI scribe to accompany us in our visits. And I've found benefit for really just basically having a secretary sitting next to me, typing down what the patient's saying. And I have patients, I don't want anyone listening. Like, I appreciate that. And I understand that concern of like, I'm sharing something very personal. I don't want anyone else in the mix. And my hope is that what we're seeing and what we've been told is what's done everywhere, that really no one is really listening in. We're just transcribing. And in the past, I would have to take mad dash notes while I was talking to a patient. And then I'd look at my piece of paper and I have to sit down. I'm like, okay, we started here and then I wrote down here. Like, if I had a better system, it would be easier for me. And I would sit down and do my take and my interpretation of the story that my patient told me. Whereas with AI, I'm getting my patient's story in their words. So and patients, I think, have really found that to be extremely beneficial.
I feel like you're able to be more present.
Right.
In
more more interact right
at
there.
the appointment, like you're able to sit down face to face and actually have that conversation with your patient. Whereas
Correct.
you're
Yeah.
not concentrating on scribbling and making sure that you get every single note. You know
Correct.
that that's taken care
It's
of.
going to be taken. Although with caution, sometimes the AA doesn't hear really well. Yeah. I went back to look at something. I'm like, I think she mentioned something about a period, and I want to be accurate. I don't want to make something. I think, and I went back, and the AI said that the patient was there for left jaw hinge pain and mass, and I kind of joked, and I was like, not my hole. So, so it's not perfect, and but that's the thing, is that it isn't perfect, and we still need to be not only present there, but then present again on the back end, continuing with that like minutia detail orientation, to make sure that what we're continuing on is the right story, is accurate. So my hope is that no one just sits back and relies on AI.
Right.
Yeah, it's a little scary.
So, in summary, do you have any other thoughts that you would like to share in terms of medicine in Medina County, or your specialty, or other things you'd like to just tell us?
I'm blessed beyond belief to have found the opportunity that I did 25 years ago when I joined the practice that I did. Change is never easy, but it's always going to come. And I'm glad that I've had support of the community, the hospital, the bigger institute, my practice, my partners, my family. Just glad I landed where I did.
Oh, and as we are as well. Thank you, Dr. McKelvey, for your time and for your participation. We appreciate it.
Well, you're welcome. You're welcome. Thank you.
Hi, I'm Maya Merheb, a gastroenterologist here in Medina.
So we are in the process of hearing the woman's voice in medicine. So, what can you just kind of give us a feel for why you chose Medina, how long you've been practicing in Medina, and so we'll start there.
Sure. I've been here it'll be 14 years in July, so 13 and a half years. And it feels like 2 years, to be perfectly honest. And honestly, there was the sense of a community hospital with a lot of need for gastroenterology. It's one of those things where there's multiple factors, but I felt like it was good collaboration with multiple other specialties, the surgeons and the anesthesia providers. And it was kind of a place where you can say, I can be here for a while. And luckily, I was right on. It wasn't an easy decision. I knew I wanted to be somewhere in the Cleveland area, and I interviewed in a lot of places, but there was something about it that drew me, the need, the importance of the work that needed to be done. And I have to say, I was very happy with my choice, and I still am.
Wonderful to hear.
Yeah.
So we've been focusing really a lot on the changes that physicians have seen, both in Medina Hospital since you've started practice, and even in your specialty. Can you kind of tell us what maybe your experience has been?
Actually, sometimes change is painful, but I think in the long run, it's helpful. We've come a long way with, better technology, better advancements, better electronic medical records. But I think there's such a high burnout with the administrative part for us physicians, the documentation, the prior authorizations, the insurance companies. So we try to focus on why we're there, the importance of patient care, and try not to let that get in the way sometimes. The future is also something, to be determined with AI in medicine, robots in the OR, where will we be? But I think we focus on the reason we chose medicine, which is to help others and make a difference in their lives. And we kind of take change with stride, one day at a time. Or else I think you drive yourself crazy.
I would agree. Do you have any special moments in your practice that really mean a lot to you?
I think it's really the people and the patients. I came into Medina Hospital a fresh graduate out of residency and fellowship. That was my first job. And I think the way the nurses embraced me in the endo center and on the floors, I got the chills. I mean, it's still one of those moments where you just don't know who you're going to get to work with, how you'll be treated. And I felt like they took me in as a daughter. From the floors to the OR staff, and, the relationships, are wonderful. They're lifelong friendships with fellow colleagues, and especially the nurses, the techs. They take care of us. They really take good care of us. And that's why we're able to take care of people and make a difference in their lives. So one of the best moments as a doctor is just hearing a patient somewhere where you least expect it, at a big gathering at St. Ignatius High School dinner, and she's telling people that person right there, she saved my life. Those are the moments that we sweat for and we work hard for, but those are the ones that you never forget.
So we've focused a lot on change, and as you've mentioned already, there's been a tremendous amount of change. What do you think is the best change in medicine to date?
I think the advancements in technology, the fact that we can diagnose quicker, we have a lot of resources to utilize, we have a lot of subspecialties even now too. Getting the patient to the right hands is very important. I feel like we have less limitations where, we're trying to reach the diagnosis quicker, and we know how to get that patient we can navigate the system better with collaboration and just making sure they get seen by the right person as soon as possible.
And you've mentioned a lot of really positive changes. Are there any changes that have saddened you to date?
I don't think it was change. I think the whole COVID era saddened me. But I think some good things came out of it. I think we've become busier as a community here. I think we're drawing from a lot of the communities surrounding Medina. We're not just taking care of people in Medina anymore. So I think it opened up various things. We're seeing a lot more pathology that we hadn't seen. So we always kind of try to see what's the bright side. And I think the bright side is, just exposure to more things and being able to help more people.
And I know you're relatively new in medicine and your practice, but is there any really good advice that you could give to physicians who are just starting out?
Yeah, definitely just remembering why you went into medicine. There's definitely easier routes and different ways, but I think the question of whether you do it again, and if the answer is yes, that's how it should be, because you have to enjoy what you're doing. You're spending more time at work than you are at home. So, remembering the reason, what is your why, the compassion that drove you to it, the calling. I think that's the most important thing to remember in the in the hardest moments.
And as a woman physician, is there any advice you would give to young women who are joining them?
Oh, yeah. I mean, I'm in one of the specialties that's definitely underrepresented by women. And I think people look at you like, why did you even choose this? But I say, when there's a will, there's a way. If this is really what you want to do, you'll find a way. Yes, it's not easy to have children during medical school or residency or after, but I think you always focus on what's important and what's going to make you happy. And I think it's very doable, and I do it again.
So glad to hear that. So for the future, particularly in Medina County, do you see anything coming in the future for Medina County?
I think continued growth. I think Medina has really welcomed a lot from various aspects. For a new president recently with a great mindset. We did get to meet with him, and he's got a lot of good plans for the hospital. They've been drawing a lot of subspecialties that we didn't have before. The orthopedic department, we're getting a lot of newer graduates that are, that have offered a lot more to the patient, to the population, and we're really serving a large amount of people.
It is so good to hear all of that. In summary, are there any other thoughts you would like to share with those who will be viewing our history of medicine in Medina County?
I honestly think Medina is a wonderful community hospital. It's not limited by a lot of restraints. We get the job done. The patient gets great care. I was always also very happy with the radiology department. In my previous trainings, we didn't get the readings as quickly as we did here. The social workers, I think the people here do really care. That's why they're in Medina. I think we all have choices, but they made the choice to be at Medina for various reasons, and the personalities and the collaboration go a long way.
Any other thoughts?
The future is ours, and we'll see how things go. It's a matter of time.
Thank you so much
Thank
for
you.
your time, Dr.
Sure.
Hi, I'm Dr. W. Danny Robertson, one of the older physicians here. I started in August 1st, 1973, took over Dr. Robert Smith's office right by the Keys Pharmacy, across from the cemetery, and came in there. I was one of the very last physicians to graduate and just come out and hang a shingle. I interviewed a nurse and a secretary, and we went out and set up our office. So we didn't have to worry about as much administration things as there are right now. But it was a good place to start, and there was big differences in this. Dr. Gary was the dentist that was starting right next to me. So I went over that day, August 1st, and say, you're starting here, I'm starting here. How about we take care of each other for the next 50 years or so? And we did. I delivered his kids, and he took care of my teeth. So it was a good relationship we have. But there is a lot of differences since I've been here. Of course, we didn't have to worry about pre-authorization and insurance at that time. We especially didn't have to get authorization for CAT scans or MRIs, because we didn't have that CAT scans and MRIs. If you wanted to know you had a brain tumor, we had to inject air in the spinal fluid and sit you up, and then see the bubble that would occur above the brain to see if there was a bulge. So that was where the brain was. And ultrasound was a brand new thing just coming out. And I remember in medical school, they showed me a hazy picture of a round circle. And it says, this is an actual baby's head. You're able to get the circumference of the baby's head from this picture. That's not going to go very far. But they finally brought out ultrasound, but it was very cautiously brought out. If you wanted to get an ultrasound on a pregnant woman, you had to have very strong indications, because we didn't know that in the future if this was going to harm the baby's hearing from the high frequency ultrasound. So it was nowadays, you want a picture of your baby in utero, you go to your doctor and he takes a picture of it, So things are a lot easier at that point, because I delivered about 1,200 babies, and not having ultrasound, I was surprised with twins. You get the baby out, and I said, "Oh my, we have a little surprise here." So yeah, and that's unfortunately one of the things that insurance has changed. They came in and told us that we no longer could be delivering babies without increasing our malpractice insurance up to $100,000 from $21,000. And so we had to shut down, and we had to get rid of 79 pregnant women. We had to promise them we'd be there for their delivery, but we couldn't deliver the baby, even though we had delivered 2 of their previous babies. So one of the little downsides we've had. And we used to assist in surgery as well too, until the insurance company decided that wasn't a good idea. The other was in blood testings. That sure has changed. We used to, in order to determine liver function, we had something called bromosulfothioline, as BSP, and it was a dye you'd inject, and then the liver would clean that out, and then you draw the blood and check for the amount of BSP. And the BSP would turn purple in alkaline. It was clear. So you do this and inject, and you go to wash your hands, and everything was purple afterwards. And in order to determine how jaundiced a patient was, you drew blood and you held the tube up, the serum up to the light compared to color charts. and that told you what the bilirubin was. So, and when I came out here, we weren't doing blood gases. I mean, now you just routinely get a pulse ox every time you go to the doctor, but that was unheard of when I came here. We didn't have any idea what the oxygen levels was or anything like this. So I gave a little talk on oxygen levels, and we just all decided that's a good idea. So we started doing blood gases. We also inserted the first pacemaker when I came here too. And then we created our first 4-bed intensive care unit, and they tried to limit that. The doctors that had admissions to it, and that didn't go very well with me because I had just finished my residency managing a 40-bed intensive care unit at Akron City Hospital. So that was one of our little conflicts. Yeah, my first office was down at 750 East Washington Street. That was from 1973 until 77. That's when Roy Miller joined me. And he was just an excellent, excellent person. He then, when he joined me, we went down then to 21.5 South Court Street, just starting down the hill. That's where the new hotel is being built now. So our office is gone. And one day we were very busy and our toilets overflowed. And we're trying to mop this up. And we hear a little rap, rap, rap from the back door. And it's Lynn Midsell with an umbrella because his office was below our office. Yeah, one day I was examining a patient there, and I heard the nurse screaming out in the hall. Yeah, and I come out, and there's this child is blue, and he's not breathing. And I grab him. I said, "Give me the intubation tubes and everything. Get ready to intubate him." And just as I turned his head, he started to breathe. I said, "Okay, I don't know what it is, but we're not moving this head." Got the ambulance, took him to Children's Hospital, and there was a brand new thing. They were able to communicate with the ambulance to the hospital. They had a telephone apparatus at that time, which was a fantastic invention. And they told us, we were able to tell them what we had coming, and they were all set. And it turned out they did an emergency tonsillectomy. This child just had huge tonsils and was obstructing his airway. So kind of a little... Yeah, I've remained at Akron City Hospital for the past 55 years as a preceptor. I work with the residents as they come out of medical school and until they graduate at the end of the 3 years. And it's getting to the point now that all I can really teach them is my mistakes. And so, but I then was able, over the 55 years, to take some of the best residents to join me. So we joined with Roy Miller, John Cerso, Glenna Jackson, Lisa Esterly, Andy Chemba, and Kristen Kranz. They all join my group now, and it's still sort of in operation. But it's completely changed how quickly they went. Last week I went down to my new office to get my annual physical, and my doctor is now the resident that I took care of. And as I go in, the secretary says, "Oh, William Robertson? Yes, just sit over there. We'll take care of you when we get a chance." You know, this is my office. But I think my history is old. It's not at all as Dr. Lynn Mansell. He was a true gentleman. He was, when I was here, they gave him an award for 55 years in practice. He started here in 1929. And I kept asking him, I said, "What did you do with things like glaucoma?" He said, "We didn't have glaucoma. People just went blind. We don't know why. They just went blind." I said, "What did you do for urinary tract infections?" "Cranberry juice." "What would you do for pneumonia?" "Mustard plasters." He says, "I tell you that one day," he said, I got on my own Model A4, took my old x-ray machine down to where 18 and 71 is now, and took a picture of a farmer's wife that had fallen. And it came back, I developed it, and I had to go back and tell him, "I'm sorry, you broke your hip. There's nothing we can do. You're probably going to die. You just have to stay here until you throw a blood clot and die." And that was about it. But even when I came here, if you fell and broke your hip, we had Dr. Zuhair Yussin came out once a week, would come out and do orthopedic surgery. So if you broke your hip on Wednesday, or you had to wait until Tuesday to get your surgery done for him to come out. Remember? So things were changed a little bit. That's where Dr. Ebner coming in was just a grace. It was just a wonderful. All of a sudden, we had our orthopedic doctor here. So he asked me what some of the upsetting things are, and that I've seen over the past few years. And I guess the most upsetting thing is the insurance companies are now dictating what we can do and what we can't do, and how long we can keep a patient in the hospital. My first experience, I was down the hall, and the nurse says, if you're going to keep this patient in the hospital another day, you have to talk to the insurance company. I said, I don't have time. You're the head of insurance utilization. She says, they will only talk to you. So she said, what is the problem? I said, well, I admitted this lady, and I went through very complex medical terms on her arrhythmia that she was having, a very dangerous irregular heartbeats, and we had to put her on a new medication to control it, but that medication might cause even a worse heartbeat. And we did, and that's exactly what happened. She went into a dangerous heartbeat. We had the defibrillator. So we were going to keep her there for another day and try another medication. And I explained this to her, and she says, you say there's something wrong with her heart? And I said, yes, she had a heart that was beating bad, and we wanted to put her on a pill that made it beat better, but we made it beat worse. So we want to keep her in the hospital for another day to put her on another medicine, but it might make her heart beat bad too. She says, well, I'll have to talk to the doctor and get back to you. And of course, when I started, my malpractice went from $400 a year to $21,000 a year. You think that's not too bad, but what if your automobile insurance went from $40 a year to $21,000 a year? So insurance companies kind of, as you know, very well know, they limit the amount of time that you can have with your doctor, and he spends so much time on administration. So if you came out for your annual physical and you had a suspicious looking mole, I said, come on, let's go across the hall and we'll just take that mole off right there. Well, now you have to reschedule that. And computers have really taken over. If I met a patient in diabetic ketoacidosis, which means their diabetes is out of control, they just push a button now, and the insulin dose is figured, the potassium levels are figured, the blood gases are ordered, the blood sugars are all ordered. They just sit back there. And if I admit a patient with a community-acquired pneumonia, I have to validate why I don't want to use this antibiotic that they prescribe. You must use this antibiotic. And if I don't want to, I have to be able to tell them why I am not going to use this antibiotic. So, and the other dismantling thing was when Cleveland Clinic shut down our obstetrical department. You know, we were delivering 400 babies a month, but we had to deliver 600 to make it apparently profitable for them. So we really missed that. And now our women all had to go to Fairview or Akron City when they're just about ready to deliver. And so that was the other upsetting thing. But what is good in medicine is the advancements we've made in diagnosis and treatment now, with MRIs and CAT scans, and they're able to treat genetic diseases now like muscular dystrophy and sickle cell anemia and things that we wouldn't even consider that. So it's made a tremendous advancement. And so I think the new medical students are adjusting to it. They're learning to run computers very well. And I tell them that just as the last thing with the medical students, they want any advice from me, I say, just remember to always put the patient first. Always put the patient's interest, regardless of what the insurance companies tell you, regardless what other outside influences are, what is best for the patient. And that's pretty much the way I ran my practice for 55 years. Thank you. That's all I have to say.
Welcome, Dr. Tulsiak.
Thank you.
We have a series of questions to talk with you about your practice here in Medina County and also at some point your leadership roles in Medina County. So to begin with, when did you begin your practice in Medina?
So I started practice in July of 1983 in Brunswick, Ohio. started practice by myself, and over the subsequent 10 years, I brought in another 3 partners until we joined the Cleveland Clinic in 1997. Then we brought another partner in.
So what are some of your first memories of your practice in Medina?
First memories of practice in Medina is, I think, opening the business and saying, "Gee, am I going to have any patients?" Thankfully, and the practice built very quickly, and I was able to bring on partners or associates at that time. One of the really awe-inspiring memories I have, though, is having one particular family that I had 6 generations in that family, where the matriarch was 104 years old when she passed away, and the youngest one was, I think, was about 2 or 3 years of age when the matriarch passed away. And the other members of the family were my patients throughout my entire career.
So in your intro, you talked a little bit about your practice, but what made you decide to practice in Medina?
So I did my residency down in Canton, Ohio, at Altman Hospital from 1980 to 1983. And during your second and third year of your residency, you start looking around. Okay, where do I want to practice? I wanted to come back up closer to Cleveland. That's where I grew up, in Parma, Ohio. And so I looked at various areas in northeastern Ohio. At the time, my brother was a cardiologist here down in Medina, and he mentioned to the CEO at the time, Ed Hall, that I was looking to start practice. He says, "I got the place just for him, Brunswick. We need someone up in Brunswick." So I met with Ed Hall, and he's a great leader. He is amazing. And he suggests I come up to Brunswick, and I did, and that was start of the history of my practice.
So you've been in practice quite a while. What changes at the hospital made the most impression on you?
The changes. Well, actually, my first impression of Medina Hospital was driving up for my interview up to Medina Hospital, and there was a circle in front of this old house, which was the main entrance of the hospital. And I thought, wow, that's rather kind of quaint. And I met Mr. Hall there in his office, and he showed me around. And there was a little diner or dinette there right in the front. And he says, "What you got to get? You got to get a patty melt. They're great here." And so I got a patty melt. But so the changes of the physical changes of the hospital changed, quite dramatically during my career. That house ended up being torn down. There was additions to the hospital. There were medical office buildings made, and then over time, the expansion of the services, an improved emergency room, improved ORs, and probably in terms for my patients, the biggest thing was the new intensive care unit, which was enabled a much higher level of care for the critically ill patients.
And in your specialty, what major changes have you seen over the years?
So in family medicine, there's been a couple of changes. Actually, all of medicine, frankly, is that there's less and less physicians who are in private practice. The financial strains in having a private practice are quite intense. And so people end up joining hospital systems or large conglomerate groups. And that enables them to overall be a bit more efficient, have a little bit more time off, they have more benefits. So that's one thing in terms of changes in family medicine. Another change is the availability of better communication. First of all, communication with a cell phone. You used to have to carry a pager around, and if you were out somewhere with your family and you got a page, you had to find out or know where all the particular pay phones were. Now you have a cell phone, and either your answering service or if your patients happen to have your phone number, you can pick up that phone and have it right there, so you don't have to be searching for a phone anywhere. I have to put a pause on that. You can edit out. I have to get my thoughts here in gear. Oh yeah, so medications, the availability of newer medications for chronic diseases has just exploded. When I started practice for medications for hypertension and diabetes, for instance, there are a few, and they help patients, but they weren't necessarily the best medications. Now there are multiple classes of medications for hypertension. There are all these newer medications for diabetes, and the one that everyone hears about now are the GLP-1s, which really help patients not only have better control of their diabetes, but also help them with weight loss. The number and different types of insulin makes it better for patients with diabetes to have better control of their blood sugars. For heart disease, statins. I think statins are probably one of the best medications that were discovered to help reduce the risk of heart disease, to help reduce the risk of vascular disease and strokes as well. In addition to that, it helps reduce the likelihood of getting recurrent heart attacks as well by lowering the cholesterol levels. So I think statins are another tremendous thing that I saw in my practice. And then finally, I think the way you communicate with patients, not only with the phone, but also with electronic medical record. It used to be that you write your note down, and that was tedious, and you probably couldn't have as accurate information as you might want to. It would take so long. Then you had dictation, which was actually quite good, but you had to have a transcriptionist. You wouldn't see that note then for several days until a transcription came back. So then you'd have to go back and review that. Now with electronic record, and the one that we have here, and pretty much all the county has it actually, all the health systems in the county use it, is called the EPIC system. And you have easy availability and of transfer of records from your colleagues, even from other hospital systems. You can see it on the electronic record. You don't have to call those other offices any longer and ask them to copy off their office visit and send it over to you. So the electronic medical record has helped in that regard in communication with your colleagues, but then also with the patient, such as with MyChart. Patients don't even have to call the office. They can just make appointments right online. They can ask their physician, their provider, questions regarding their medications or a particular issue, and the provider will message the patient back. So that's a great innovation.
So as a family practitioner, what was the most poignant memory that you've had in your practice?
When I started practice in 1983, I also delivered babies. And so it was a true family practice. You delivered babies, you took care of the pregnant mom and then the newborn, and right up until, as I said earlier, 104-year-old patient. So I think a poignant thing was, I remember the first time I took care of my first delivery was a pretty special thing. I didn't continue doing deliveries because it was extremely stressful and it was hard to to get time out of the office to run on down. You have to tell patients who are in the office, oh, sorry, I have to cancel your appointment because I got to go run down to the hospital and deliver a baby. So I stopped delivering babies primarily for that reason. But that, and then also a very, probably the most poignant thing about family medicine for me is the relationships that you build with your patients. You actually became part of their family. In some cases, even deeper. I had patients tell me that they would share things with me that they wouldn't share with their spouses or their children or even their minister or priest. So that's a pretty special relationship that a family medicine doc or primary care doc can have with anyone. Actually, I really miss it. That's the thing I miss about medicine being retired, is the relationships with the patients.
So what advice would you give practicing physicians today?
Take time to know your patient and their families, as well as take a thorough history and do a thorough physical exam. Because one thing that hasn't changed in medicine from time that I was in training in the 1970s, late 1970s when I was in medical school, and then 80 to 83 in my residency, and then subsequently, one thing that hasn't changed is that you can get 80% of your diagnosis on a patient by doing a good history and physical exam. Because whether a patient knows it or not, they'll tell you what's wrong with them. They'll tell you the diagnosis. They may not know the words, but they know their symptoms. And if you take a good history and follow that up with a good physical exam, you'll have your diagnosis. And the diagnostic tests then, or the technology, will only confirm that. So don't depend just on technology. Take a good history, take a good physical exam.
So what do you see as the future of medicine, both in your specialty and in hospital
So for family medicine, there's less and less people going into family medicine as physicians. And part of that is because of the reimbursement rates. Insurance companies don't pay doctors to think so much anymore. They pay doctors to do. And I think my family medicine colleagues would agree with me on that. So you see less people going into primary care, whether it be pediatrics or internal medicine or family medicine. And they're doing the subspecialties because they know they can get reimbursed at a greater rate. So I have a concern that there's going to be inadequate, already is an inadequate number of family physicians. I think that's going to get worse. And I think it's going to be a detriment to our health system and our health care. Because although nurse practitioners do a tremendous job, my daughter's a nurse practitioner in family medicine. Although she does a tremendous job, her training is not at the same level as a physician, no matter how many years of practice she's in. She just not going to have the experience. And you can't gain that. You don't have all the basic knowledge that you get during your medical school and residency training that would put you at the same level as a physician. So I have that concern in terms of the future of family medicine. Hopefully the family doctors don't think that this is a 9-to-5 job, because it's not. It has to do with relationships and with patients, and you need to spend the time with patients.
So you've had several leadership roles.
Mm-hmm.
What was that transition from a practicing physician to a leadership role? And what do you see as benefits or as advice for other physicians who might want to go into leadership?
When our group joined the Cleveland Clinic in 1997, the person who recruited us was Dr. Dave Bronson. He was a tremendous leader at the clinic. He started all the regional family health centers and then subsequently became the president of all the regional hospitals. But he asked me to be the medical director of our family health center in Brunswick. So that was my first exposure of taking a leadership role, other than being the senior member of our group. And I enjoyed that. That was just on top of everything else I was doing. So I still had a full practice and had the responsibility of being a medical director, which was basically managing the practice and the staff, and to a greater degree as the practice got larger. And then in 2009, when Medina Hospital was looking for a partner, they chose the Cleveland Clinic. And I was asked to be the vice president of medical operations, or chief medical officer in other lingo. And again, that didn't really significantly change my responsibility with patients. It was just an added thing to do. And then in 2011, I was asked to be the hospital CEO or hospital president. And that's where that time commitment was so great that I reduced my practice time to about 30% clinical. And I always used to say, well, it was 100% CEO or hospital president responsibilities and 30%. So I was working 130%. I used to joke around about that. But I thoroughly enjoyed it. I had a great team. And they are the ones who made the hospital work. They're the ones who made the hospital work. I had an excellent chief nursing officer and an excellent director of quality care, Fran, and an excellent COO, and the entire team was just tremendous. It made my job thoroughly enjoyable. So my advice to physicians, if they're looking at leadership roles, I think go for it. You learn a lot that you're not taught in medical school or residency. And if you're with a large hospital system, they give you all the tools you need. You're going to classes, you're going to all kinds of meetings for leadership training and management skills, and they do that for all the hospital leaders. So I'd say do it if you're interested in that. If you just want to take care of patients, that's all, then each hospital system has that availability as well. One of my younger colleagues from my practice in Brunswick, he wants nothing to do with practice management. He just wants to see patients, and he's a dynamo. That's all he does, is take great care of patients.
So in summary, do you have any other thoughts you would like to share, either about practice of medicine, practice of administrative leadership, any other thoughts?
Yeah, I think that medicine has changed so much that just as physicians find it difficult to be in private practice, and there are still some who are in private practice, but for the vast majority of them, they find it difficult to just be alone or even in a small group. Just as it is for physicians, hospitals have found the same thing, because the cost of running a hospital is very difficult with the way insurance reimbursements are and government subsidies are. And so you see hospitals joining systems. That's why here in Northeastern Ohio, there's 3 systems basically that control all the hospitals: Cleveland Clinic, University Hospitals, and Summa Health System. And hospitals join these hospital systems because they find it's better off for them financially, or they're able to bring in new services that they didn't have before. And that's exactly what happened here with our hospital, is that there's expanded in new emergency room, renovated in new ORs, additional vascular labs, a wound center, okay, new subspecialties that we didn't have available to us before. So I think, there's always pros and cons when you are affiliated with someone. And our group, my group of colleagues, after we joined the clinic and we looked at things 5, 10, 15 years afterwards, we said, well, did we make the right decision? We said, oh, heck yeah. Why? We had more time off. Instead of only being able to have 2 weeks vacation, we ended up having 6 weeks vacation. Instead of having 1 week of conference, we were able to have 2 weeks of conference. We had better life insurance. We had disability insurance that we didn't have before. Better retirement plan than we were able to provide for ourselves. Okay? So the pros far outweighed the cons of having Big Brother over your shoulder. And luckily our Big Brother was Dave Bronson. And, he kept an eye on things, but he didn't interfere with the way we were practicing. Yeah. He was a great boss. So.
All right, well, thank you so much for your time and for your information.
My pleasure. Thank you for inviting me.